நான் பாசிட்டிவ் நான் கவனிக்கும் போது இல்லை அந்த 10 minutes this is going to heavy, so I can put it like this. It is going weird, sir. But it is very, very long. No problem.
Good morning, esteemed colleagues, distinguished guests, and participants, both in person and virtually. It is, I'll talk. It is a privilege to welcome you all to the International Conference on Sleep, hosted by the Department of Psychiatry and the Medical Educational Unit at Sree Balaji Medical College and Hospital. Sleep is a fundamental biological process that plays a pivotal role in maintaining our overall health. Today, as we delve into the various aspects of sleep, from its physiology to its influence on psychiatric and respiratory health, we will explore how sleep impacts everything from emotional regulation to cognitive function. The sessions ahead will not only help us better understand the connections but also will guide us in applying this knowledge to clinical practice. Let's now begin the conference with an inaugural address by Professor Priya Shivashankar, HOD, Department of Psychiatry. Professor Priya Shivashankar is not only a respected academic and clinician, but also a very visionary leader in psychiatry. Her dedication to mental health care and academic excellence has transformed the department into a center of learning and innovation. Let's now proceed with ma'am's address.
Good morning. Good morning. Good morning. I'm very happy to be here. I welcome all delegates from different fields, from physiology, from medicine, and obviously psychiatry, to this international conference, Sleep 360 Degrees. There are various quotes about sleep. One of them being, sleep is the sovereign physician. I hope the physician in this room will not take offense to this, but there are many studies, many things which show that sleep is very important for our mental health, as well as respiratory health, immune health, cardiac health, metabolic health. So we'll be talking to you about this conference. Our speakers are going to delve across various aspects of this conference. Let us now begin the first session. The first session is chaired by Dr. Anand, and the speaker is Professor Devaki. Please welcome to the stage, ma'am. Thank you.
It's my pleasure to introduce Dr. N. Anand, Professor and HOD of General Medicine, who will chair the first session on the physiology of sleep. Professor N. Anand is distinguished academic and clinician with extensive experience in general medicine. He is a fellow of the Royal College of Physicians, Glasgow, and the American College of Physicians. Professor Anand is also a member of American Diabetes Association and the Indian Medical Association in Tambram. He has authored more than 50 manuscripts and contributed 18 books and monographs to the medical society. Professor Anand has presented at numerous national and international conferences, sharing his expertise across a wide range of medical topics. In recognition of his contributions, he was honored with the COVID Warrior Award in 2021 by the Tamil Nadu Health Minister. His wealth of knowledge and leadership makes him a highly respected figure in this field. It is with great pride that I now invite Dr. N. Anand to introduce our esteemed speaker.
Okay. Sir, I like to thank the
head of the Department of Psychiatry as well as the Department of Psychiatry for inviting me for this conference. So I have been practicing for the last 27 years, and over a period of time, I am seeing a sea change in diabetes, which is my primary area of interest. Where the awareness of diabetes is increasing day by day. Nowadays, the patients are very much aware that they stick on to the medications and make regular exercise and regular checking. But still, getting control little bit difficult. And we have seen increasing number of patients with sleep disorders over the periods. 25% of my practicing my patients in practice are devoid of sleep to various reasons. So this conference, Sleep 360-degree, is apt at this point of time. So now going into this, the first topic going to be delivered by Professor Devaki. She is the head of the Department of Physiology, Sree Balaji Medical College and Hospital. She has 7 international journals to her credit and 10 national journals. And she got the second best prize for the faculty paper presented at AppCon 2015. So she is going to deliver about physiology of sleep. So please don't sleep, awake and listen. And once again, I thank the organizers. Now I call upon Madam to take the lecture.
Yes. Thank you, sir, for your wonderful introduction. Very good morning to all. And I take immense pleasure in thanking the Department of Psychiatry. They are very much into physiology. Always they support the physiology department, and they think that physiology, they understand the concept that physiology is the basics of everything. So that's why I think they have put the first talk as physiology of sleep. And I think today it is the National Sleep Day. So in that occasion only, I think you have organized this activity, this CME. So I again thank you for giving me the opportunity to learn many things about sleep. I learned many things, and I'll be sharing my knowledge with you, the little knowledge which I have gained in this field of physiology of sleep. Next slide. It's not changing. Okay, so I think all of you will agree with this, that sleep is the single most effective thing we can do to reset our brain, body, health each day. So each day when we sleep, we reset our brain, we reset our body, and we get up new, fresh the next day. So the most important thing, most important function of the sleep is to have regeneration of our bodily functions. Okay. So these are my objectives: to define sleep, to discuss the need for sleep, describe the types of sleep, list and describe the different stages, and describe the variation in sleep pattern and sleep duration with age, and list the neuronal structures and neurohormonal substances involved in sleep, describe the role of circadian rhythm, explain the process of sleep-wake cycle, and list the sleep disorders. So almost 1/3 of our lifespan we spent in sleep. If the average age is 75 years, almost 25 years we sleep. Okay, but do we give such an importance to sleep? Like, do we think that whether we are maintaining the sleep hygiene, whether we are taking proper precautions to get good sleep? All these things are questionable. So this is the importance, the paramount importance they have given to sleep. And that's why I think they have dedicated a day for sleep, National Sleep Day today. And also I think this month, the whole month is for sleep. It's a month for sleep studies and everything. So we can understand the importance of sleep, and yes, we should understand the physiology and all the other aspects of sleep for us to become aware of the various aspects of how to maintain a good sleep and what are the factors which will influence the sleep activity in the body. So coming to this, to honor the scientists who have discovered many, there are milestones in the sleep medicine. So in this day of National Sleep Day, we would like to honor all the scientists, at least few scientists who have made some discoveries in this field of sleep medicine. So it started in 450 BC. Alcman was the first Greek physician who first documented the observation of sleep and the stages of sleep. You can see that Pliny, he was the person in 2379 Christian era, he discovered the stages. There are different stages of sleep. And Hippocrates, we all know about Hippocrates, and he only identified the importance of sleep for physical and mental health. And following that, Aristotle, the great physician and scientist, he correlated the process of digestion with sleep. And Kleitman, he is considered as the father of sleep research, and he was the one who also did several works in REM sleep. He found out how this REM sleep occurs and everything. So the sleep-deprived animals secreted sleep-inducing substance. Henry was the scientist who discovered it, and Constantin, he identified hypothalamus is the center for sleep, and this has made a lot of contribution. Like now when we are going to see about how the sleep is induced, how the sleep-wake cycle occurs, we will understand the importance of hypothalamus in the sleep-wake activity. And this biological clock, what we are calling as a circadian rhythm, it was identified by Bunning in 1935. And stages of sleep. Now we have 3 stages, but initially they thought it was 5 stages. And this was identified by Loomis, Harvey, and Hobart. And first in 1953, they discovered REM sleep in an young boy. Melatonin, we all know, it is a sleep-inducing substance. This was discovered in 1958. And distinction between NREM and REM sleep was done by Jowett. The circadian rhythm was identified and named by Hallberg, who is considered as the father of chronobiology. And Jowett, again, he identified that Pons regulates REM sleep. VLPO, this is an area in the anterior hypothalamus. This was found by Sapper, and we will see how this area also is responsible for regulating the sleep-wake cycle. Then synaptic homeostatic theory was stated by Tonani and Cyril. 2003. And of course, there is continuous process going on, doing lot of discoveries and inventions and new concepts in sleep. So with this, we'll start with the definition. We'll go into the proper subject. So sleep, I think we cannot give a, definite definition for sleep. There are many things which combines together, and that is how we can define sleep. But in Guyton, it is given as a state of unconsciousness from which the person can be aroused by external stimuli. We consider Guyton as our Bible, so we take the definition from Guyton. So it is the state of unconsciousness from which the person can be aroused by external stimuli. And this has to be differentiated from coma, which is a condition from which the person cannot be aroused. But this is not the single definition. We can see that in sleep, when the person is sleeping, the bodily functions are periodically rested. And also it's an unconsciousness which is produced by the body, where the brain is in a relative state, but then it is reactive primarily to the internal stimuli. We sleep and now only we have this alarm clock and everything. Even if we keep the alarm clock, there is an internal clock in our body. There is an internal stimulus which makes us to wake up. So in response to this internal stimulus, we will wake up. And this sleep is characterized by low physical and reduced sensory awareness. So there are a lot of definitions, but the first one is the definition which we take for sleep. So why do we sleep? What is the reason? Why should we sleep? There are many reasons. And as I told you, first thing is to restore our mental and physical health, rejuvenation. Okay, so that is what is the most important function of sleep. Then There is consolidation of memory, cognitive functions and memory should get consolidated. And when we sleep well, we try to remember things which is needed for us, not the one which is not needed. The things which are needed for us, we try to remember. There is synaptic network getting strengthened when the activity of sleep happens. And energy conservation, we have a whole day of tiresome work, and at the end of the day we need some rest for us to conserve the energy so that we can recoup ourselves for the next day. So that is one another reason, and it enhances the overall survival. And as I told you, there is targeted erasure of synapses to forget unimportant information. What is unimportant? That is, it is up to us to decide. But whatever unimportant informations are there, it will get erased. So we will get up fresh the next day to have some more work to be done the next day. Okay. So these are the needs. Why should we sleep? These are the reasons for which why we should sleep. Okay. Now coming to the stages of sleep. So as you know that there are two phases or types of sleep. One is the REM sleep, which is nothing but the rapid eye movement sleep, and the non-rapid eye movement sleep. So what is the difference between these two sleep is that the REM sleep has eye movements, okay, and this sleep is also known as the paradoxical sleep or desynchronized sleep, and NREM sleep is the slow wave sleep. We will see what further as we describe the characteristics of these REM and NREM sleep. We will see what are the differences in these two types of sleep. And these two types of sleep, actually, they are identified. And further, these NREM stages are identified by two things. One is the characteristic features which are present in these sleep patterns, like the decrease in blood pressure or respiratory rate, etc., BP, etc. And also the waves which are found in this in the brain with the help of EEG, whatever is recorded in the waves which are recorded. From these waves also we will identify the different stages and also the different phases of sleep. This NREM sleep is further divided into different stages. Initially, there were 4 stages. Now, in 2007, the American Academy of Sleep has modified these stages, and stage 3 and stage 4 has been combined. And this is the 3rd stage, and we have the REM sleep. So totally, there are 5 stages: wakefulness, N1, N2, N3, and REM sleep. So these are the 5 stages. So as I told you, these stages will be identified based on the EEG waves and also the characteristic features like the decrease in blood pressure, associated movements, etc. So what is this first stage? Whenever we talk of this stage, it is important that we should talk from wakefulness. Sleep means it is not REM, NREM. Wakefulness is also important because as soon as we lie down, we don't sleep. We remain wakeful for some time. So there are 2 stages of this wakefulness. One will be the alert wakefulness, and another one will be quiet wakefulness. What do we mean by alert wakefulness is that we remain in the bed with eyes open. We will be thinking of many things like what should we do next day, what happened today, all these things, okay. And nowadays, the recent trend is that we look at the mobiles, okay. So that's why the light is going to interfere with your melatonin secretion, and that's why the sleep latency is increased. That is why they ask us to, we have the 10-3-2-1 rule in which they ask us to stop using mobile well before we go for the sleep, okay. So here, this is very important. The eyes are open and the person will be alert and he'll be in a awakened state. How will you identify this stage is that the beta waves will be prominent in this stage, okay? And this beta wave is the wave which is similar to the waves which are present in alert condition, awake state. And these beta waves, they have very high frequency and they are not synchronized, they are asynchronized, desynchronized waves. Okay, so immediately we will not be in that state for a longer time. We try to close our eyes, and this is known as a quiet wakefulness state. The patient becomes drowsy and close their eyes. But this is not where the sleep starts. This is a stage in which suddenly, if you remember, oh, I have forgotten to keep a particular thing, means you will get up and you will go and you will do that job and you will come back. Okay, so this is a quiet wakefulness state. So in this state, we will have the alpha waves predominantly, and the frequency of this alpha wave is less, okay, when compared to the beta waves. The thing is, suppose if you remember something and if you open your eyes, then it causes alpha block. Immediately, the beta waves will take over. So this is the difference between this alert wakefulness and quiet wakefulness, okay. So coming to this sleep, we have different stages, NREM and REM. So in this NREM, we will see into the stage 1 of NREM. So this is a light sleep. So we can easily wake up that person from this stage of sleep. Okay, if you just call the name, they will be able to wake up. So this is what is light sleep. Light sleep. The duration of this light sleep in the whole sleep duration will be 5%, but it lasts for 5 to 10 minutes. Okay, means the whole sleep cycle, this duration of this light sleep will have only 5%, but it lasts for 5 to 10 minutes. In each sleep cycle, it will be lasting for 5 to 10 minutes. Okay, when you look at the EEG recording in this stage, predominantly it will be having theta waves, but initially they will be having alpha waves. The alpha waves will be recorded in the EEG. So what is the difference between these alpha and theta waves is that the theta waves are relatively low, they have lower frequency and higher amplitude. Okay, so this is a transition phase between the awake state and the sleep. So it's just there, you are drifting into this sleep. That is what is the importance of this stage 1. Now, stage 2, this is a deeper sleep. So this is not the light sleep, this is a deeper sleep, and it constitutes about 45% of the total sleep duration. So the time, it lasts for 20 minutes, but the stage 2 is the one which will be predominantly present in all the sleep cycles. So it occupies almost 45% of the total duration of this sleep. Okay, and here in this stage 2, the body goes into deep relaxation. There will be a drop in temperature, heart rate, everything will be reduced, and you will become less aware of the surrounding. Okay, so that is what is stage 2. And this sleep, it is mainly identified by the sleep spindles and K complex, which will be present in the EEG. So these sleep spindles are nothing but rapid bursts of high frequency waves, and theta waves will be predominant in this stage 2, high frequency brain waves. And this sleep spindles, they are important for the process of learning and memory consolidation, etc. will happen in this sleep spindles, especially the procedural and declarative memory. These are very much concerned with this memory of different types of memory. Then this K complex, it's a very high amplitude delta waves, and it lasts for approximately 1 second. And this K complex is also helpful in sleep memory consolidation. Okay, so this is how we will identify stage 2, K complex and sleep spindles. Now coming to stage 3, this is what is the slow wave sleep, the deepest sleep. So once we enter into this sleep, it is very difficult for any of our near and dear to wake us up, because this is the deepest phase of the sleep. Okay, so it lasts for about 20 to 40 minutes, and it constitutes 25% of the total sleep duration. And there will be a decrease in BP, respiratory rate, everything will be there. The delta waves will be very predominant in this slow wave sleeps. These waves they will have very low frequency, and that's why they are called as slow wave sleep. And suppose if you are going to wake up a person from this sleep, the person will be having mental fogginess, and this we call it as sleep inertia. Okay, so but the importance of this sleep is that the body repairs itself, bone growth, muscle growth, everything, in strengthening of the immune system, everything happens at this stage. So this stage of sleep is very, very important. But this does not occur throughout the sleep duration. It is there for only few initial sleep cycles. Now, the sleepwalking, the parasomnias like sleepwalking, night terrors, bedwetting, everything occurs during this phase of NREM sleep. So we will see about REM sleep. So the REM sleep is, it occupies almost 25% of the total sleep duration. The thing is, it's a paradoxical sleep because we term it as sleep, but the brain remains alert. The metabolic rate is more, the brain metabolism is very high, almost 20% more than the normal. And suppose if you are going to wake up that person from that sleep, it's very, very difficult. There is a decrease in the external arousability, but it is this REM sleep stage from which the person always awakes. Okay, so the internal arousability will be more, whereas the external arousability is less in case of the REM sleep. It's known as paradoxical because of this difference, like they are at rest, but their brain is very active. And this REM sleep, when you look at the EEG finding, the beta waves will be prominent, and these are the waves which are desynchronized and they are present during the alert stage. So that's why it's also known as desynchronized sleep. Okay. So now the most important finding in this REM sleep is the occurrence of pontogenic-low-occipital spike, which is nothing but the stimulation of neurons from the pontine lateral geniculate body, and it goes to the occipital cortex. So when we record the EEG, we will be getting this pontogenic-low-occipital spike. And this is an indication for sensory motor integration, this pontogenic-low-occipital spike. So these are the various EEG waves. We can see that the first thing is the alpha waves. So here the frequency, we know that, beta waves. In awake state, we'll be having the beta waves, stage 1, the theta waves, the sleep spindles, the kick complex, and we have the delta waves. And this is the REM sleep, where again we'll be having the beta waves. So these are the EEG recordings of the different stages of sleep. This is the sleep hypnogram. So we all know that this is the graphical representation of the different sleep cycles. And what do we, when we look at this graph, we can see that the total duration of sleep is about 8 hours. Yes. So here in the x-axis, we have the hours, and in the y-axis, we have the stages, N3, N2, N1, REM, and awake. So we can see that almost 5 cycles happens in this 8 hours, 5 cycles of sleep. And this is alternating with REM, awake, NREM, and REM. It doesn't start with REM. So you're not having any recordings here. You're not having a red mark here. These red marks are the REM sleeps. Okay. So it starts with awake stage, alert awake, and quiet wakefulness. Then the person goes in for the stage 1, stage 2, stage 3. And as I told you, the deepest deepest stage of sleep, it doesn't exist for a longer time. Only for the initial 3 cycles, you will be having the deepest stage of sleep. All the other cycles, it will end with the deeper stage, the stage 2. Okay. So what is again the striking thing is that the REM sleep duration gradually increases. You can see that the period of REM sleep slowly increases as the time passes. And what is this? This is from the person awakes from the REM sleep. We told that it is from the REM sleep, the person will be waking up. So the person awakes from the REM sleep. So this is what is the hypnogram. It's a graphical representation. So the characteristic feature is we have in an 8 hours cycle, we will have almost in 8 hours sleep duration, we will have almost 5 sleep cycles. And the N2 is the one. We saw that it contributes almost 45% of the total sleep duration. Even though it lasts for a smaller time, it is present in all these cycles. And that's why its contribution is greater when compared to N3 sleeps. So sleep stage. So in this N3 sleep stage, we can see that it is present only in the initial 3 cycles. Okay. So this is the deepest sleep. Okay. So are we getting enough sleep? Are you feeling sleepy now? Yes. Okay. So we know that the duration of sleep is not same for an infant and for old age. It is different. Okay. So it's not only the duration, the pattern of sleep is also different. It is not the same. So that is what we are going to see. So this is the difference in the duration of sleep. As you can see, as it is known to us, the newborn, the newborn sleeps for a longer time. The sleep requirement itself is very long. And as age advances, we can see that over 18 years of old, the sleep decreases to about 7.5 to 9. But now the new normal is we will have only 5 hours of sleep, not more than that. Yes. So because we have a lot of other works to do, especially students, they want to watch mobiles and reels and everything. So, but the sleep requirement, whatever we have to have is 7.5 to 9 hours of sleep. So the sleep pattern, it also varies with age. As you can see, this is the graph. And in this graph, we have the x-axis in which they have plotted the age, and in the y-axis, the hours of sleep. And what is characteristics of this graph is that the NREM sleep, of course, it's more in the initial phases, in the initial age. Here, this age, initially it is in months, and as time goes by, it is given in years. So initially it will be more, but this REM sleep duration, initially it was more, but as time passes, what's happening? It is getting decreased. The percentage of REM sleep is less in case of an adult when compared to the newborn. Okay, so this is the most characteristic change which we need to note in this graph. And we can see that the period of wakefulness is increasing from 16, I mean, from almost 5 hours to 6 hours. It is going on increasing, and at last, at this age of, I mean, above this adult age, it almost, except for that 7.5 to 9 hours for which the sleep is required for us, all the other times we are awake. Except for the students who also will sleep in the classrooms. They will have larger sleep duration. Okay, this sort of sleep, we can say that it's anticipatory sleep, or an ultra short nap, or a short nap, or it can be an anchor sleep also. Okay, so this is the variation in the sleep pattern. Now, look at this newborns, 16 to 18 hours of sleep. Okay, what are the characteristic features of this sleep in the newborn is that the sleep stages, there are 3 stages: quiet sleep, active and indeterminate sleep. And the sleep will start with REM cycle, because till 2 months of age, their circadian rhythm is not developed for this newborn children. Newborn baby, infants, newborn, I should say it as newborn only, because after 2 months, it will, the circadian rhythm will set. And after that, what will happen? It will get regularized. The sleep cycle will start with NREM as it occurs in adults. Okay, so the shift in REM to the later half of the cycle will occur in case of a child of more than 3 months. And each cycle will last for about 50 minutes, unlike in case of adults where the cycle will be for 90 minutes. Okay, and in 6 months, they will be having 6 continuous hours of sleep. And in 1 year, they will be sleeping for about 14 to 15 hours. How lucky they are. 14 to 15 hours of continuous sleep. But that sleep also nowadays, it is reduced, because even a 1-year child is able to look at the YouTube video and everything. Okay, so this is the menace of the recent mobile phones. Okay, so here this sleep, 14 to 15 hours of sleep, it's mostly in the evening. It doesn't occur in the morning time. Only 1 or 2 short naps will be there in the morning time. In toddlers and children, the REM sleep latency will be more, in the sense they will be having more of N3 stage of sleep. The deepest stage of sleep will be more in toddlers and infants. They will be having more deepest. That's why when you have children of this age group, 3 to 9, it's very difficult to wake them up, because they will be almost very much, they will be into this N3 stage. Okay, and the onset of latency, this REM sleep will occur a little later. Normally it is 50 to 150 minutes, but in case of these toddlers, it will be postponed. It will be taking a longer time. And adolescents, of course, there will be a decrease in this N3 stage, but they will be having predominantly N2. Okay, and also they will be having, very important point, they will be having daytime sleepiness. That is the reason why our students are sleeping in the class. This is because of the hormonal changes which occurs during puberty. So we should not get offended if they are sleeping. The nature itself has provided them in such a way that they will have daytime sleepiness. Okay, adults, of course, they will get up early, they will sleep early, and but the thing which we need to remember is the consolidation of memory is decreased in case of adults. It is less when compared to the children and toddlers, because these children and toddlers, they spend more time in deep sleep, deepest sleep. So they are having good memory consolidation. In older age, it's almost like the adults, except for they will wake early and they will sleep early also. So that is the menace we have when we have elder persons in our homes, because they will ask us to wake along with them and sleep along with them, which is not possible for us. Okay. So coming to the sleep-wake cycle, the sleep actually it obeys circadian rhythm as well as the ultradian rhythm. What do we mean by? Actually, sleep is the circadian behavior that is composed of ultradian stages. So that is how we should say sleepers. Okay, so circadian rhythm is nothing but it's a 24-hour internal clock which is regulated by the suprachiasmatic nuclei, which stimulates the pineal gland to secrete melatonin. Okay, and this responds to the light changes which happens in our environment. But nowadays it has evolved so much that it need not have any light or night changes. Okay, it can happen by itself due to the clock that is set in the suprachiasmatic nuclei, that itself will, adjust, and accordingly the circadian rhythm will happen. And ultradian rhythm is controlled by the brainstem. That is what we will see when we are going to describe the different stages of sleep. And there is oscillation between REM and NREM sleep in case of ultradian rhythm. In the hypnogram, we were seeing about the different cycles going from REM to NREM to awaken from REM to NREM. So this is what is the ultradian rhythm. So this is a circadian rhythm. So we can see that day, night. Okay, so the most important part which takes place in the circadian rhythm is the suprachiasmatic nuclei and the pineal gland. The pineal gland is here. So here, when at daytime, okay, there is inhibition. Melatonin is known as the sleep hormone. So at daytime, there is inhibition of melatonin secretion, and that is because in daytime, what happens is there is stimulation of this retinal ganglionic cell, and this sends the impulse through the optic nerve to the suprachiasmatic nuclei, and this will secrete an inhibitory neurotransmitter, GABA. This will inhibit the pineal gland. So when it is inhibited, what happens? There is decrease in the melatonin secretion. So that is what is causing melatonin, that is inhibition of melatonin secretion. Melatonin is not secreted during the daytime. But as time passes, as evening approaches, what happens? There is this light stimulus is removed. So what happens is this suprachiasmatic nucleus, it is removed from the stimulation of this retinal, light impulse, as a result of which it will not secrete the inhibitory neurotransmitter, namely the GABA. So this pineal gland is not inhibited by the GABA, as a result of which it will secrete melatonin, and this melatonin is what is making us to sleep. It is responsible for sleepiness. Okay. Sorry, I think this is not working. Okay, okay. So this is how the melatonin, when the melatonin is secreted, how does it cause sleepiness? And there are two functions of melatonin. One is to cause sleepiness, and another one is to bring about the synchronization of light and dark cycles. Okay, so when melatonin is secreted, this acts on the melatonin receptors, which are present in the heart, in the cardiovascular system, in the blood vessels, in the retina, and also in the suprachiasmatic nuclei. So this melatonin acts through the MT1 receptors and MT2 receptors. When it acts through MT1 receptors, this is what is responsible for causing sleepiness. It inhibits, it's an inhibitory, it acts through GI, okay, inhibitory receptors, and it inhibits adenyl cyclase, causing sleepiness. Whereas when it acts through M2 receptors, this is what is responsible for this synchronization of light and dark cycles, that is the circadian rhythm. Okay, so what happens here is the change occurs at the level of the genetic level. So during night and day, we can see that during daytime, we have 4 genes which are concerned with this suprachiasmatic circadian rhythm. One is the declock gene, the cycle gene, the per and tim gene. So these are the 4 genes. Just remember this, during daytime, this declock gene and this cycle gene, they will cause the formation of this per and tim heterodimer. And during night, what happens from the cytoplasm, this per and tim heterodimer will enter into the nucleus. And once it is inside the nucleus, it will inhibit the declock gene and cycle gene, which in turn will be inhibited, and there will not be a production of this per and tim heterodimer. That is what is causing this cyclic pattern of suprachiasmatic nucleus, which is responsible for the day and night cycle of the circadian rhythm. Okay. Now coming to this ultradian rhythm, we know that there are different parts in the neuronal parts which are responsible for this ultradian rhythm, sleep-wake cycle. And the most important ones will be the hypothalamus and the reticular activating system of the brainstem and the basal forebrain. These 3 are the most important structures, neuronal structures, which are concerned with this ultradian rhythm. Of course, we have other neuronal structures also, like the suprachiasmatic nuclei, the thalamus, the pineal gland. We know what is the role of this pineal gland and suprachiasmatic nuclei. Thalamus, this is the release center. All the sensory information, all the neuronal tracts, it will go through the thalamus, both sensory, motor, as well as this emotional component. It will go through the thalamus, and finally it will get projected into the cortex. Okay, So now this basal forebrain is another most important structure which is concerned with the process of REM sleep. The wake-on neurons and the NREM-on neurons, they are present in this basal forebrain. We have amygdala and hippocampus, which is concerned with emotions that are associated with sleep. We have the lateral prefrontal cortex, which are concerned with the thoughts and judgments which happens during the REM sleep. And we have the angular cingulate gyrus, which are very much responsible for the vivid dreams which happens in the sleep. So these are the various neuronal structure. Just remember these three important structures, namely the hypothalamus, the reticular activating system of the brainstem, and the medial forebrain. And also these are the three important structures about with which we will be dealing with the next slides. Okay, so in the hypothalamus, we have two nucleus, tubulomammary nucleus and the ventrolateral preoptic nucleus, VLPO. Okay, so I have given different colors. These colors, the blue colors, these are all the areas in which we have neurons that are concerned with wakefulness, wake-on neurons. These neurons are known as the wake-on neurons. So the locus coeruleus, which is presenting in the RAS, it will secrete norepinephrine, dorsal raphe nuclei will secrete serotonin, and tuberomammary nucleus will secrete histamine. These three substances are very much important for this process of wakefulness. They are known as wake-on neurons. Okay, and here we have this ventral, again in the hypothalamus, we have the ventrodorsal tegmentum nuclei. No.
Previous clicker will work now. Clicker,
Yeah, okay.
clicker. I don't see that.
No, I want that first slide.
Now it will work.
Okay, so we have the lateral dorsal tegmentum nucleus, which is present in the reticular activating system, and the pedunculopontine tegmentum nuclei, which is also present in the reticular activating system. Both these nuclei, they are concerned with secretion of acetylcholine, which is very important for the REM sleep. So they are known as the REM-on neurons. Okay, so the red colors, they are REM-on neurons. And also in the medial forebrain, we have two group of neurons. One neuron will be the neuron which will be secreting acetylcholine, and we call that as the acetylcholine secreting neuron, which is concerned with NREM sleep. And we also have the pedunculopontine nuclei. We also have another neuron which is there for regulating the REM sleep. We call it as REM-on neuron. So these basal forebrain, it has GABA secreting neuron, which is concerned with the NREM sleep, and we have the acetylcholine secreting neuron, which is concerned with REM sleep. So this is how these are the neurotransmitters or neurohumoral substances which are responsible for inducing the sleep-wake cycle. So we have to remember that in case of the hypothalamus, we have the anterior nucleus which is present in the anterior hypothalamus, and we have the nucleus which is present in the posterior hypothalamus. Yes, so this nuclei, you can see the tubulomammary nuclei which is there in the posterior hypothalamus, and the locus coeruleus and dorsal raphe nuclei. All these things are concerned, they are known as the wake-on neurons. They will secrete histamine, serotonin, and norepinephrine. Okay, and in case of the same hypothalamus, the anterior hypothalamus, it will have the VLPO nuclei, which will secrete GABA, and we also have the basal forebrain, which has GABA secreting neuron as well as acetylcholine secreting neuron. Okay, so along with this VLPO, this basal forebrain GABA secreting neuron is responsible for NREM sleep, and this acetylcholine secreting neuron of this medial forebrain and the LDT and PPT of the reticular activating system is concerned with REM sleep. So when there is interaction between this posterior hypothalamus and the anterior hypothalamus, there will be switch happening between wake and NREM. When there is interaction between this locus coeruleus and DRN and this LDT PPT, there will be switch between REM sleep and the wakeful sleep. Okay, and when there is interaction between this reticular activating system and the hypothalamus, there will be transition between NREM and REM. So this is what is basically the thing which you need to remember when you have the there is for this sleep-wake cycle. Now, as we all know, the first stage of this sleep is wakefulness, right? So wakefulness, and always we should remember that there should be, it's not a balance, it's like a seesaw action. So sleep and wakefulness is like a seesaw action. So it's not changing. It's like a sleep seesaw action. So when the sleep neurons are more activated, it will cause sleep. When the wake neurons are more activated, it will cause wakefulness. So there will not be a balance between these two. Either one will be high and another will be low, or this one will be high and this one will be low. There never can be a balance. So always we should remember that whenever you want the person to be awake, then this wake-on neurons should inhibit the sleep-on neurons to produce wakefulness, right? And whenever you want the person to sleep, the sleep neurons should inhibit the wake-on neuron to produce sleep. This is what is the basic thing which you need to remember. Whatever circuits I am going to tell further, all this it depends on this basic thing only. Inhibition of wake-on neurons cause sleep. Inhibition of sleep neuron will cause wakefulness, okay? Now coming to this may appear to be a complicated one, but this is easier if you have understood the neurohumoral substances and the centers, okay? So this is what is happening in wakefulness. So we know that during wakefulness, what should happen? The wake neuron should be activated and the sleep neuron should be inhibited, right? So here we have these wakeful neurons as the tuberomammillary nuclei, and the reticular activating system has the locus ceruleus and dorsal raphe nuclei. These neurons, these nuclei are concerned with the wakefulness. So what should be done is that this tuberomammillary nuclei, which secretes histamine, this inhibits the NREM. We have two types of sleep, NREM and REM sleep. So both these things should be inhibited, right? So this histamine, it will inhibit the NREM on neuron, okay, which is in the basal forebrain bundle, and also this VLPO, which is in the anterior hypothalamus, which is responsible for this NREM sleep, okay? And this LC and DRN, they will secrete norepinephrine and serotonin, and this will inhibit the REM neuron, which is secreting acetylcholine, okay? So there is inhibition of the NREM sleep, as well as there is inhibition of the REM sleep. So this is what is causing awakening, okay, wakefulness. Now, we also have this histamine. The interesting thing is this histamine also will stimulate this acetylcholine secreting neurons on both these sides, from the basal forebrain bundle as well as from the LDT and PPT. So in wakeful state, there is also some acetylcholine which is present, which maintains the wakefulness along with this histaminergic norepinephrine and serotonin. So when you look at the neurotransmitter levels during this wakefulness, it will be like there will be increased norepinephrine, serotonin, as well as the histamine, but acetylcholine will be there in little amount, GABA will be very less. So this will be the neuron transmitter picture in case of a awakened condition or wakefulness, okay? Now this has occurred because the neurons, the wake-on neurons has inhibited the sleep neurons. Now what is the next stage? It is the NREM stage, right? So in the NREM stage, what should happen? Now this wakefulness has occurred, but it has to be sustained for some time, yes or no? Immediately we cannot go in for either the wakefulness itself should be sustained, and even if it is a wakefulness before the sleep, it is taking some time, almost 5 to 10 minutes for us to sleep. So this sustaining of wakefulness is done with the help of an hypocretin wake-on neuron, which is a neuron which is present in the lateral hypothalamus. Hypocretin or orexin wake-on neuron, which is present in the lateral hypothalamus. So this hypocretin wake-on neuron is what is known as the sustaining nucleus. So it sustains the wakefulness, sustains the wake state, okay? How does it sustain this wake state is that we know that this histamine, we saw that it also stimulates the acetylcholine secreting neuron of these wake-on REM neurons, and also it stimulates the LDT-PPT, okay? In the previous slide itself, we saw that, along with inhibiting the NREM on neurons. So what does it does? This acetylcholine wake-on REM neuron, this will stimulate the hypocretin wake-on neuron in the lateral hypothalamus, and this in turn will have a stimulatory effect on this TMN neuron secreting histamine. So this inverted L is an positive feedback loop which continuously happens to make the person wakeful for a longer time. But this can also not happen for a longer time. It has to get stopped somewhere, okay? So how does this occur? We don't have a specific, as far as I know, I read the books, there no clear picture has been given like how it is stopped, but it has been suggested that this hypocretin vagal neuron, it stimulates this histamine as well as it will stimulate the secretion of norepinephrine and serotonin. Okay, excite this norepinephrine and serotonin. These norepinephrine and serotonin, actually it has an inhibitory effect on this hypocretin vagal neuron. You can see that it is marked in red. So in this way, it can inhibit the hypocretin vagal neuron. But this norepinephrine and serotonin, they say that it is not a powerful inhibitory effect. It doesn't have a powerful inhibitory effect because they themselves will inhibit their action of secretion. So they are not very powerful. So as much as these vagal neurons are active, they will remain active and then they will go in for the next stage, that is NREM stage. Now, this is how it sustains. Okay. Now, when we have to go to the next stage, that is NREM sleep stage, it is necessary that either this hypocretin vagal neuron should be inhibited or this NREM on neuron should become more powerful. So these are the two ways by means of which we can switch to the next stage, that is NREM stage. So this hypocretin vagal neuron is known as the switch neurons because this is what is responsible for this switching from this wake stage to the NREM stage. Okay. So now here there are two mechanisms by means of which the NREM on neurons can be activated. So first, let us see about this hypocretin vagal neuron. There are various factors which will influence this hypocretin vagal neuron. Like for example, if a person is well fed, okay, his leptin level and glucose level will be more. So what will happen? We feel like sleeping. Yes. How it occurs is that this leptin and glucose will inhibit this hypocretin vagal neuron. So it is influenced by the environmental hues. Okay. And suppose if the person is hungry, will you be able to sleep? No, we will not be able to sleep because we have ghrelin, which will stimulate the hypocretin vagal neuron. Likewise, we know the effect of suprachiasmatic nuclei. We saw earlier that by means of melatonin, it will maintain the, it acts through MT1 receptors, and this causes sleepiness by inhibiting this hypocretin vagal neuron. Likewise, amygdala, which is concerned with emotions, depending upon what type of emotions you have, whether you are happy or depressed or sad, either it will stimulate or inhibit this hypocretin vagal neuron, and thereby it can make the person to sleep more, or it can make the person to not sleep at all. Okay, so there is a difference in this activity from the amygdala. So once this hypocretin vagal neuron is inhibited, what will happen? This will not stimulate the histamine, right? So there is no excitatory effect of this hypocretin vagal neuron on histamine. So this positive loop which is happening here, which is helping us to sustain this wakefulness, will not be there, as a result of which the person will go for this NREM sleep stage. How is he going for this NREM sleep stage? Is that by making this once this histamine is inhibited, okay, in histaminergic neuron is not stimulated, its inhibitory effect on NREM on neuron will also go off. So the NREM on neuron will become more powerful, right? So still we have to make it more powerful for the person to switch to this NREM stage of sleep. So how this is made is that when the person is awake for a longer time, there is accumulation of substance known as adenosine, okay, in the basal forebrain. So what this adenosine do is that, see, this NREM neuron, apart from being inhibited by this histamine, it is also inhibited by some other inhibiting neurons. What this adenosine will do is that it will inhibit this NREM inhibiting neurons. So what will happen? It will disinhibit this NREM neurons. Okay, so the NREM neuron will become more powerful. So once it is becoming more powerful, what it will do? It will inhibit the histamine. It will also inhibit the hypocretin. So the cycle is lost. Okay, so this wakefulness is also decreased, and also this NREM neuron is becoming more powerful. Okay, so this is how the NREM neuron, when it becomes more powerful, it helps us to switch to this stage from wakefulness to NREM stage. Okay, suppose if a person is consuming coffee, what happens is the person will not be able to sleep. The reason being this caffeine, it will inhibit, it will, this adenosine, it has a receptor to act, right? So this caffeine, it will go and stick on to these receptors, and it will inhibit the action of this adenosine, as a result of which the person will not be able to go for NREM sleep. The person will be awake. So this is the reason why caffeine is making the person to stay awake. Okay. So now we should also remember that this NREM on neuron, it's also inhibiting the histamine. It will also inhibit this locus coeruleus and dorsal raphe nuclei. Okay. So now, because the next thing what should happen is the switching from this NREM to REM. I don't know why it's okay. Switching from NREM to REM. So for this switch to occur, the REM neuron should be activated. Okay, so the REM neurons, it should be activated. How does this REM neuron gets activated? The thing is, we saw in our earlier slide, this NREM on neuron, when it becomes powerful, it will inhibit histamine, and also it will inhibit, sorry for this arrows, which is, it's not seen because of this icons. So it also inhibit the locus coeruleus and DRN. Okay, so this locus coeruleus and DRN, it will secrete norepinephrine and serotonin. This was inhibiting this LDT and PPT, and this LDT and PPT secretes acetylcholine. This is what is responsible for the REM sleep. Yes. So now, since these neurons, these nucleus, this locus coeruleus and DRN, when they are inhibited, there is no secretion of norepinephrine and serotonin. So this inhibitory effect goes off, and what will happen? This acetylcholine REM neuron will be activated, and there will be switching off to the REM sleep. From NREM sleep, it will go to the REM sleep. Okay, so here we can see the NREM on neuron, it inhibits histamine, as well as it inhibits the locus coeruleus as well as the dorsal raphe nuclei. So there is no secretion of norepinephrine and serotonin. So this inhibitory effect goes off, and this will stimulate the acetylcholine secreting neuron, that is the REM on neuron, which will go make the person to switch to the REM sleep. Now, next to the REM sleep, what is that? From the REM sleep only, the person is waking up, right? So here, sorry, I think there is some problem with that. Okay, so this is, it's not coming actually, I don't know. Oh, okay, okay. Previous slide. So wake on neuron. So now for the person to become awake, the wake on neuron should be activated. So how does this wake on neuron, how does it gets activated? We know that here we have a loop where there is a feedback inhibition from the histamine to NREM and NREM to histamine. So here the wake neurons will inhibit the NREM on neurons. But here there is a cycling behavior. The wake neurons will inhibit the NREM neurons, but REM neurons. But these REM neurons in turn will stimulate the wake neurons. Instead of inhibiting, they will stimulate the wake neurons. So once these REM neurons are inhibited, because of the inhibitory effect of this NREM on neurons, this neurons will become activated, this LDT and PPT, these neurons will become activated, and they will stimulate norepinephrine and serotonin. And we know that these are the wake on neurons, and this will produce wakefulness. Okay, so this is a cycle. So what you need to remember, what we need to remember is that we have several neurohumoral structures which are involved, which are secreting different types of neurotransmitter that are involved in the transition between the wakefulness to NREM to REM. And all this should happen in a proper way, because when there is a delay in the onset of sleep, that's also a problem. When there is a delay in this stages which is occurring, if a person is going to sleep from wakefulness to REM, then it will be a problem. He has to go through the proper stages, right? Then there should be proper duration of sleep which should occur, and the person should also be wake up for a proper time. He should not be having daytime sleepiness. So all these things should be maintained. So that is how this sleep-wake cycle, with the help of this circadian rhythm, is able to maintain the sleep-wake cycle through day and night. By means of this brainstem regulation, it is able to make the person to go through the different sleep-wake cycles, and thus make the person to have a good sleep. Okay, so sleep disorders, I think there are experts who will talk about sleep disorders. Just to list out for completion's sake, and just listing out the sleep disorders. There are different types of sleep disorders. We know it's insomnia, which we all know that it's difficulty to fall asleep. It can be, there is sleep insufficiency. It can be either due to not able to sleep throughout the night, or maybe they are getting up early. That is what is the cause for insomnia. And sleep apnea, of course, it's a separate topic which has to be discussed. And narcolepsy, this actually is a chronic neurological disorder which is caused by brain's inability to regulate the sleep-wake cycle. So instead of going into NREM and then into REM, the person directly goes into REM sleep. So it is this narcolepsy, it's this condition in which we'll have cataplexy, sleep paralysis, etc. Okay, and periodic limb movement disorder, it is just like the restless leg syndrome which we have when the person is awake, and this will make the person to have flailing movement of the limb. This will make the person have sleep disturbance throughout the night, as a result of which he'll be having daytime sleepiness. Then parasomnias, as we have already discussed, these are present in the NREM stage of sleep. It refers to the somnambulism, which is nothing but night walking, nocturnal enuresis, and night terrors. Okay, so we have delayed sleep phase disorder and advanced sleep phase disorder, which occurs when there is some disorder in the circadian rhythm. What do you mean by delayed sleep phase disorder is that till 1 a.m. the person will be awake, just like how they are doing in IT and all, okay, awake, and they will be sleeping only after that. When they are going on doing this, in case of IT people, this is a disorder. But in case of IT people, what will happen? Their circadian rhythm will get itself changed in that way. Okay. So advanced sleep phase disorder is that by 6 o'clock they will start sleeping. Not in the morning, in the evening, 6 o'clock they will start sleeping. So this is what is the advanced sleep phase disorder. Okay. So these are my references. And I think you all will agree that sleep is an investment in the energy you need to be effective for tomorrow. Okay. Thank you. Thanks once again for giving me this opportunity.
It is a very exhaustive and a very outright physiology. You have taken us to a physiology, good physiology class. Okay. Any doubts from the audience? Any questions or queries? I'd like to ask a question.
Yes, sir.
In our practice, many times we see these patients coming and complaining that I don't get an adequate ruling out your disorders like sleep apnea and other things. I don't feel fresh. Even I sleep, you close my eyes, I remember things around. I don't feel fresh when I wake up. So these kind of persons, do they don't touch the deep sleep phase, or they just from the initial phase, they come to N2 and then again the REM and then go back?
It is possible, sir, actually. By what I understood, I think only in the initial 3 cycles, sleep cycles, they are having the deepest sleep. So unless they have this deepest sleep, I think they'll not be feeling fresh. That is the thing. Maybe because of various influence, because of some emotional disturbance or some other issues, there may be some inhibition which is happening at the level of this hypothalamus. There may be some inhibition happening in this ultradian rhythm, which may affect, and it is possible that they don't go in for this deeper sleep at all. They will wake up, but the deeper sleep they will go, but also this deeper sleep, I don't know how much level they will be able to sustain this deeper sleep. Maybe that may be the reason, but I'm not very confident about what may be the problem. Having gone through all these things, I think that it is possible that they will have some abnormality. Mainly the emotional concept, maybe it is the one which is hindering with their sleep cycle. I think so.
During the aging process also,
Yes, sir.
There also the deep cycle they don't touch.
They don't touch, and also they say that there is a change in the circadian rhythm also, because old people mostly they confine inside the room, they don't get exposed to the light, and they will have an abnormality in the circadian rhythm also. That may be the reason for them getting disturbed sleep. And as we saw, they sleep early and they wake up early, and also they will have some other as I said earlier, some other emotional components which will make them to feel less sleepy during the night time. That is why they are having increased daytime sleepiness. Maybe that's the reason.
Thank you. Thank you.
Thank you.
Thank you, ma'am, for your excellent and detailed presentation on the physiology of sleep. Your explanation of the stages of sleep, including REM and NREM, along with the role of circadian rhythms, was enlightening. Understanding the biological process behind sleep provides a crucial foundation for the discussions we'll have throughout the day, and our insights have set the perfect stage for our conference. Your contribution has truly deepened our understanding of how sleep functions within our body, and we are grateful for the clarity and expertise you have shared. I now request Dr. N. Anand to kindly felicitate Dr. P.R. Devaki for her outstanding contribution for today's session. Thank you, Dr. Anand, for chairing the session so well. We now request Dr. Priya Shivashankar to felicitate Dr. Anand for his valuable role as chairperson. Moving on to the next session, I now invite Dr. Kailash Suresh Kumar, Professor and HOD of Psychiatry, Chettinad Hospital and Research Institute, to chair the next session on approach to insomnia. Professor Kailash Suresh Kumar is a renowned academician and clinician, especially in psychiatry, currently serving as a professor and the HOD of Psychiatry at Chettinad Hospital and Research Institute. He is also a key resource person for postgraduate students and doctoral scholars in the field of psychiatry. With a medical degree from PSG Medical College in Coimbatore and further specialization from King George Medical University in Lucknow, Professor Suresh Kumar has significant expertise in adult geriatric and addiction psychiatry. His awards include MV Ashok Memorial Award for Best Research Protocol in 2024 and MAMR Muthaiya Award for Excellence in Research Publications in 2023. He is also a convener of the Spirituality and Health Task Force at the Indian Psychiatric Society. With over 40 index publications, his contributions to research and clinical practice are highly valued in the psychiatric community. I now welcome our Honorable Chairperson, Dr. Kailash Suresh Kumar, to introduce our esteemed speaker.
Thank you, Dr. Priya Madam, the Vice Principal and the Chairman for this opportunity. I welcome Dr. B. Venkatesh Kumar, Professor Psychiatry, Madras Medical College.
Zoom stream matrix, sir.
And the
Zoom
areas of
stream
interest are
ಆಗಿದೆ.
general
ಅದನ್ನ
psychiatry,
ನಾವು
child psychiatry,
கண்டிப்பா
social psychiatry, and legal psychiatry. He has authored many books.
parallel போகும் சார் நீங்க இதுல பேசலாம்
Made psychiatry module for general hospital
இது wired
doctors. He has made a module for treatment of substance use disorders. He's authored a book on skill development for child and adolescents. And he is a renowned academician. He is an expert in the field. Moving on to the topic, it's such an interesting topic and approach to insomnia. Now, this, as Madam has highlighted, this insomnia has reasons ranging from complicated syndromes like ECMOMS, Klein-Levin syndrome, to normal issues like dry skin, itching, bed bugs, snoring of the partner, drinking coffee late at night. So when the causes are so much varied, you have to make a diagnosis to make a proper treatment. Sometimes if you treat everything with sleep medications or benzodiazepines, the underlying cause like apnea might worsen. So making the right diagnosis and approaching it with proper history and examination would be of paramount importance. And I leave it to an expert for the discussion on the same. Thank you.
Pointed.
Phone. This is
Yeah.
so at the outset, I sincerely thank the Balaji Medical College and Department of Psychiatry, HOD ma'am, and our colleagues, Dr. Gayatri and Ramya, to give this opportunity. So I'm very upset because two things. Madam வந்து ஸ்லீப் பத்தி பேசினோடனே இதை நான் வந்து ஸ்லீப் ஆயிடுவோம்னு நினைச்சு வந்தேன். பட் இந்த மேடத்தோட ஸ்பீச்ல வந்து நாட் ஓன்லி ப்ராக்டிக்கல் தட்ஸ் மோட்ஸ் ஆஃப் தியரி. ஸோ ஐ வில் பி அப்செட் வித் நெக்ஸ்ட் டாபிக் இதே தான் நான் பேசணும். மேடமே எல்லாம் பேசின மாதிரி இருக்கு. ஸோ மேடம் வில் ஃபினிஷ் எவ்ரி திங். ஸோ மை ஜாப் ஆல்சோ மே பி ஈஸியர். ஸோ ஐ எம் நாட் எக்ஸ்பர்ட் இன் திஸ் ஸ்லீப் இன்சோம்னியா. ஐ எம் நாட் ஈவன் ஹேவிங் ஸ்லீப் ஈஜெல்லாம் ஒன்றும் பெருசாக பண்ணது இல்லைங்க ஐஎம்ஹெச்ல. ஸோ வி நாட் ஹேவ் எனி எக்ஸ்பர்ட் இன் திஸ் ஏரியா. பட் வி ஹேவ் சம் தியரிட்டிக்கல் நாலேஜ் ஆர் ப்ராக்டிக்கலி நாங்கள் காயத்ரியோட நாங்கள் ஒன்றும் காயத்ரி அம்மையோட ஒன்றும் பெருசாக தெரிஞ்சிருக்க முடியாது. பட் அவுட் சைட் ஸ்பீக்கர்ஸ் வந்து நாங்கள் வந்து ஜாலியாக வந்து பேசிட்டு போகிறோம். தட்ஸ் ஆல். ஸோ ஐ சின்சியர்லி தேங்க் ஹெச்ஓடி மேம் டு கிவ் திஸ் ஆப்பர்ச்சுனிட்டி. ஸோ இன்சோம்னியா காயத்ரியும் மேடம் சொன்னோடனே ஐ பிகம் ஆன்சைட்டி வெதர் ஐ பிகம் இன்சோம்னியா ஃபார் த பாஸ்ட் 4 or 5 days. ஸோ திஸ் வெரி டிஃபிகல்ட். ஸோ கமிங் டு த டாபிக் பர் சே, இன்சோம்னியா அப்படின்னு சொன்னோடனே நம்மளுக்கு என்ன நினைவுறது அப்படின்னா the lot of things to be there. மேடம் எல்லாம் சொன்னாங்க what sir will ask the questions, how is define insomnia, the lot of ways to define, but the lot of books says that, but two criteria nowadays more important, either DSM-5, we follow either DSM-5 or international clinical sleep disorders. The two criteria are nowadays more important. The first criteria we have say that the subjective complaints of the sleeps, that's more important. That's why the subjective sleep complaints, what the ma'am told, that subjective sleep complaints, this is the three important area to have. No, sorry. So the subjective sleep complaints, have three components. The first component say that I am having initiation difficulties, so I go to the bed, I'm not able to sleep initially. But first criteria is initiation of difficulties. Second important point is I go to sleep, but I'm not able to sustain my sleeps. So that is called as middle insomnia, or middle insomnia. And third one is we call this early morning awakening. So the three important subjective complaints to more important to diagnose insomnia. That's first important criteria. The second important criteria is associated with sleep difficulties. So the associated with sleep difficulties, that means maybe early morning, what are the other madam told that I am maybe fatigue, my memory have difficulties, my concentration not able to do that, and have the impairment my day-to-day activities. This is the two important criteria to say that have insomnia. So the first is important is subjective complaints of I have difficulty initiations, or my middle insomnias, or my early morning awakening associated with these symptoms like I'm not able to feel fresh, I'm fatigued, I'm always sleepy in the mornings, I'm not able to concentrate, I have difficulty in my jobs. It's impair my day-to-day activities. These two important criteria to say, then only you have to call this insomnias. But there are other criteria for that. One of our driver came to me one day to how I have insomnia. So they asked the persons to say that, what is your sleep times? He told that I am working in the morning 4 o'clock up to night 12 or 1 o'clock. So my driving, he's working in a private college. He morning, 4 o'clock, he took the drive bus and he finished all the rounds and go to bed in the around 1 o'clock. So there is no opportunity to have a time to sleep. That is one of the important criteria, that adequate opportunities are present. When there is a third important criteria, if I have an adequate opportunity to sleep, and the frequency and durations. How, when you diagnose frequency, most importantly, then DSM-5 say that at least 3 days per week. If I have a 3 days per week and at least minimum 3 months, then only we diagnose these things. So these are the important 5 criteria symptoms to say that I have insomnia. And another important point is it's not attributable to other disorders. suppose what Sir told us is attribute to some other disorder as medication induced, substance induced, then we don't diagnose as insomnia. So there are a lot of new criteria. Previously, when our students, we talk about insomnia, we talk about pathophysiological insomnia, paradoxical insomnia, like so many different terms we have nowadays used, but the terms nowadays have deleted. So insomnia is a broader spectrum. These complaints 3 times a week and more than 3 months, we call it as insomnia diagnosis. And second, that's why that the criteria for that nowadays. Yeah, the criteria average sleep time latency is more than 30 minutes. Wakefulness after sleep onset also more than 30 minutes. My sleep efficiency is 85%. It's less than 85%. That means there are calculations there. I'm always weeks in max. So total sleep time divided by total bedtime. I'm correct. Is okay. Denominator and numerator. Total sleep time divided by total bedtime into 100. We can able to calculate the sleep efficiency. If efficiency is more than 85%, we don't diagnose sleep disorder. If the sleep efficiency is less than 85%, only able to diagnose sleep disorder, and the total sleep time is less than 6.5%. So even madam say that nowadays even 5 hours, but the book says that less than 6.5%. So there are a lot of pathophysiology and psychiatry itself. Even madam says that madam is more important for us because psychiatry is a branch of medicine that deals with human mind. The mind itself is a physiology, it's not a pathology. So physiology is more important for us. So mind itself a pathology, physiology of the brain neurons. So what are the causes for a psychiatric problem? We always called as biopsychosocial model of illness. The biology is genetic vulnerability, and the physiology is, we know, psychology, we know the personality factors and social factors are there. So the pathophysiology of sleep disorder also, they're more important, the biopsychosocial model of illness. So there are a lot of P's, we remember with P's, predisposing factors. I am predisposed to certain disorders. That's why like sleep insomnia also I may be predisposed. My genetic vulnerability and epigenetic factors may contribute my predisposing factor. And precipitating factor, most of the times patients complain that after a severe stress, for example, like financial loss, death of someone, I have job loss, some other infections or medical comorbidities, the precipitating even most of the time by the stressor of the lives and by perpetuating factors, most of the time I'm maladaptive thinking. So if most of the times people go after 2 or 3 weeks, if I go to bed, I think that whether I'm able to sleep today or not. That's one of the important complaint patient always say that. If I go to bed, that itself create an anxiety to the persons. So that itself the maladaptive, the perpetuating factors. So the 3 P's are important for every psychiatric diagnosis. So it's a predisposing, I am predisposed to individual. That's why madam talk about so many genes, the clock genes and other genes that are important. There are vulnerability in the clock genes also nowadays. There are a lot of other genes vulnerability like 5HT genes, and a lot of genes abnormality were found because most of the studies say that twins we have insomnia problems very heavy. The hereditary factors are very high in insomnia. That's more important factor. And important psychological factor, I always worry about my problems and so many other factors, these are there. So finally, what is the common theme for that insomnia? That the common theme for my insomnia is hyperarousal state. That's why. This is the insomnia is the hyperarousal of the night. So if your wakefulness is hyperarousal in the morning, the insomnia is the hyperarousal in the night. So that is called as excessive physiological and cognitive arousal, and the physiological conditionings is one of the important factors for insomnia. So we say that madam also told that there are a lot of other neurons, neurotransmitter, norepinephrine, epinephrines, and histamines, which are very called as wakefulness. They are very alert in the night. That is why it's called as a hyperarousal in the night. Yes. Sorry. And this is a heightened sensitivity, my tendency to worry excessively. And most of the time, insomniac patients are called as they are more worried about their somatic complaints and an internalizing personality styles. They are not usually externalizing that, and selective attentional bias. And daytime, they may require great effort to sleep. This is important factors in physiological and cognitive arousals. And the next point is bedtimes and routines, my physiological changes, physiological conditioning arousals associated with my bedtime and bedrooms activities. These all leads to chronic insomnias. So how to know that hyperarousal state? There are a lot of studies say that we have hyperarousals by that heart rate variability, my core body temperature and other basal skin resistance and HPS activity, immunological cytokines. But even EEG itself, madam, what told that we even during this type of insomniac patient, they have more of beta waves during our EEG findings rather than like the theta waves. Most of the times they have more of beta waves activities during nighttime. And the MRI changes, what they found that the metabolisms were during equivalent to wakefulness. There are a lot of areas, madam told that, but in the wakefulness state, they have hypermetabolic state. Even during insomniac patient, also they have equivalent to a hypermetabolic state during the MRI finding. So these findings say that this is the insomnia is a state of hyperarousal. Sorry, I don't know. Sorry, I'll do something mistakenly. So I am in a state of hyperarousal, so I do mistakes. So this, I don't know, madam will tell that VLP or ventrolateral and other areas of the brains, pineal gland, thalamus. I'm not going details. So the diagnosis of insomnia, there are a lot of ways classify, but this is the way to classify intrinsic factors and previously primary and secondary, circadian mismanagement, social behavior, and psychiatric disorders. But that we mostly worried about this primary insomnia. This is called as, this is because of the primary insomnia, sleep state misperception. This is the state we sometimes patient have sleep, but objective evidence of EEG also say that patient in sleep, but the patient complains I'm not able to sleep. This is called as dissociation in psychiatry. Most of our psychiatric patients, especially chronic schizophrenic, sometimes they have state of sleep state misperception, and other things are very nightmare disorder and everything. Sir told us snoring. This is one of the important complaints. The snoring OSA is not the problem of the sleeper, the problem of the bed partner. Sometimes the bed one, even one film also came that based on that snoring. I think so. I know the name of the part. And cardiac misalignment, advanced phase, delayed phase, irregular sleep cycles, and most of the time social behavior, one of the important cause for primary insomnia. Insomnia, we adapted certain rules and regulations, what madam told, seeing TVs and cell phone in the nights, most probably, taking caffeines in the nights, of heavy exercise in the night. Sometimes even heavy exercise in the night have disturbed sleep wake pattern in the night. So these are our social factors and psychiatry. And most of the times we have in IMH, we don't see primary psychiatry. Primary insomnia is the common cause for our diagnosis. Most of the times we have to find underlying any psychiatric problem. Most of the time is either depressions or anxiety. You know that depression is affect REM sleep patterns. So most of the times we found that either general anxiety disorders or depressions or substance use is the common cause for insomnia. The primary insomnia, we have not any experience. Only one or two cases we have seen in our practices. So the epidemiology, and during my study, this epidemiology, I go to the articles, when only I surprised that female have insomnia. I don't know why, I don't know that. And old age because of the natural factors. So one of the important factor I found that female more commonly affected than males. And most of the times, 50% of the insomniac patients have associated, they have some either medical or psychiatric problems. So this is an important indication, either medical, most important, even pain, one of the important risk factor for insomnia, chronic pain symptoms, one of the important risk factors, and other psychiatric problem, and substance abuse, most probably even alcoholic. There's a misperception in alcohol intake. Most of the times people think that if you take alcohol, you have a good sleep. But after some time, alcohol have produced a fragmentary sleep pattern. It's disturb our REM sleep pattern. So we have always fragmentary, and especially during withdrawal also. So this is a modern epidemiological studies say that. And complication, you know that in a lot of factors, madam will also told that obesity important factors because of the hormonal changes, cardiovascular, lot of factors. But one finding during my studies, I found that suicide one of the important complication of sleep deprivation. Even without any even comorbid conditions, suicide may have an independent risk factor. So insomnia is one of the important independent risk factor for suicides. So if you have chronic insomnia, they go for suicide, one of the important factor. And suicide, Tamil Nadu is the second important leading cause. So we can aware that if you treat in sleep insomnia, the suicide rate may be come down also. And this is not the way to how to go for what are the things you have to go for insomniac patients. So these are nighttime symptoms, sleep onset difficulty, what are the awakening times. And most of the times, the awakening frequent and duration, associated symptoms we have difficulty returning to sleep, And difficulty returning sleep, most of the times also people also think that if I get up, I go to bed. Usually I have a time of 20 minutes latency. I go to bed, I can go sleep. So most of the time people even think that itself a problem. So if I get up from the bed, I immediately go to bed, I go to sleep. But most of the times it at minimum 20 minutes to go back to sleep. But most of the time people don't think that. So difficulty returning to sleep, we have to mention that behaviors during night. That's more important. That's why some patient will get up and see again to the cell phone. It's again sleep, it causes problems. Early morning awakening. It's minimum, you have to say that at least minimum 1 hour. Then only we call it 10 to 15 minutes before that, we don't think it's early morning awakening. So minimum 1 hour, then we call it as estimated sleep amount. That's why we call it as sleep efficiency and sleep quality. Most of the times people think that I have adequate sleep, but I'm not able to feel fresh in the morning. That's important complaint of sleep quality. And daytime symptoms, that's more important. Because even I not have an insomnia 5 hours sleep, but daytime I have no problems. Then you do diagnose of insomnia. That's more important. If I have problem during my daytime is impairment in my day-to-day activities, only we think it's insomnia. Otherwise, most of the politicians and others, they are only sleep for 4 hours. They can able to work very nicely, but they don't diagnose of insomnia. So the daytime symptoms more important: sleep, fatigue, sleepiness, mood symptoms, and most of times irritable and cognitive, most memory difficulties, proneness to error. And some studies even I go to, there are equal to taking alcohol. Sleep insomnia is equal to taking alcohol, doing some errors in their driving and everything. So they have an accident. And one time I went to an Ola driver. He described he suddenly stopped a car in the signal. After that he slept. There are a lot of traffic because he immediately slept down. So everybody came and pushed the door. And he suddenly go for deep sleep in the 5 minutes, 10 minutes of his traffic signals. So people afraid of that he may be died. Afterwards he woke up. Sometimes that's more important. So proneness to error and these are very common after insomniac presence. Diminished quality of life and functional impairment. This is very common. And our cause of sleep disturbance and pre-morbid sleep patterns more important when it's onset. That's why I told most of the time it's a precipitating event. Associated circumstances, we know that mental life circumstances, perpetuating factors is more frequency of insomnia symptom, durations, acute and chronic and severity, and sleep-wake schedules, how it's affected. So these are important points to remember in our history takings. Pre-sleep condition, most important. Usual evening routines, mental state during going for that. That's why if you go to bed only, I think I'm worried about all my problem. Definitely it causes sleep disturbance. That's why we always, I told to patients like tea time, we have keep a worry time in our routines, but it's not near to the bed. It's always keep in evening 4 o'clock or 5 o'clock. So you have to keep all your worries at that time, and we have to get rid of the worries. So that's more important. Mental state, bedroom environment, light, noise, temperature. But I have wondered whether these are for insomnia patient. But I saw people in the road, they even so many sound, light and everything, but they sleep very well in the roadsides. So why it's happened, I don't know. Sleep surface, we saw that so many activities, but people in outside, they sleep very well. Activities in the bed, that most of times we have to do activities in the bed. So my chief always say that bed is only for 2 things, sex and sleep. But most of the times we do in other ways. We studies, we see cell phones, everything in the bed. So that itself a great problem for insomniac. And bed partners that I will told a voice equation. Daytime napping, that's also more important. We are not able to sleep in the day. Usually napping time nowadays, lot of studies that if you want a nap, it's only 20 minutes. It's very difficult. You cannot not more than that. How it's possible, I don't know. So one day I tried, but next day I become very, that day I get up, it's very severe headache. So now next day onwards, I not try that napping. But if they say that if you have 20 minutes napping in the daytime, your energy become more. People say that nowadays that is called a super napping. That's name given that super napping like that because our energy is more. But the napping time is also more important. You cannot do this napping before 5 hours going to the bed. So if you want to napping, it's usually in the daytime, not in the evening and other times. So that napping is more important. And typical daytime activity, exercise, light exposure, fatigue countermeasures. That's more important. Without physical activity, we have sleep disturbance, definitely. Because of that's why I always encourage it in things in my treatment point. Yoga, one of the important point. I not talk about politics, but yoga more important. You have sleep inducing promoting agents. So breathing, that's why additional witness, the body movements, urine frequency, and other things. That's why pain, one of the important contributing for insomnia. So differential diagnosis, I don't go it. That's why it's all sleeper who sleep only 5 hours, but they don't have any complaint in the mornings. And behaviorally induced sleep restrictions, that's why I told the driver who have not able to sleep proper times. Sleep disturbed environmental circumstances, the circumstances have caused sleep disturbances. Other thing, more or less, you know that other circadian sleep disorder, that's my delayed phase and early phase symptoms. Sometimes the persons go delay only, they go to bed up to only 2 o'clock in the night, but they get up in the morning at 11 o'clock. That is called delay phase. Early phase, most of the time they go in the evening at the 6 p.m. itself and get up in the 4 a.m. in the morning. That also problematic. And sleep-related breathing problem and restless syndrome. I'm very, I go to the article nowadays that the latest criteria we called as UDGE, one of the important criteria, mnemonic they have given us UDGE criteria. That's why I want to teach people and to move legs associated with unpleasant sensation. Most of the time, restless syndromes, we know that commonly we encounter in our psychiatric practices, the patients, they want to move the legs, especially during the nights. And the rest is worsen the symptoms. Usually rest will relieve symptoms of other condition, but in restless syndrome, rest will worsen the symptom. So they want to move the legs. So it's not accompanied by other medical or behavioral conditions. So that's one of the important criteria. Restless syndrome, what egg-bomb syndromes are, sometimes they can ask even PG questions are neat also. So madam will simplify and madam will, I will not go in deep in. So sleep promoting neurotransmitters. The 3 things are GABA, melatonin, adenosines, and other wake promoting neurotransmitter, orexin or hyperactin. This is the latest neurotransmitter we find identified. Because the orexin and hyperactins are the same neurotransmitter, but they founded 2 persons, they are the same time. So they initially thought that this is a secretin like, or somebody say that is a orexin like symptom. So that's why they put the name orexin or hyperactin. And this is the one of the important way, madam, this is not directly act on MAC promoting, but it's act through these receptor. So the orexin is and hyperactin is are not directly acting on any wakefulness, but it's act through histamine, acetylcholine, dopamine, serotonin. That way induces wakefulness. So nowadays so these 2 things neurotransmitter. So it's a sleep promoting. So we have to drug uses these either GABA or melatonin or that inhibitor. So the 2 things are drugs. So either GABA promoting drugs or wake promoting inhibitors. The 2 things are usual for our treatment of insomnia. So this is the latest benzodiazepines available. So these are the drugs which are available. But I don't think India don't have these drugs, ma'am. I don't know. So this is, but this is the indicator hypnotic drugs for benzodiazepines. So you know that benzodiazepines is the GABA receptor activity, and this is not specific activators. So they call it as heteroreceptors. There are a lot of subtypes of GABA receptor. You know, not alpha, beta, gamma, delta. But most of the benzodiazepines are found between the alpha and delta units. Between them, they can act. So GABA, what will do that? The benzodiazepines usually is an inhibitory. So they can cause us chloride channel open. When the chloride channels were open, they cause us hyperpolarizations. That's the important part. So when hyperpolarization, I become very calm. So these are the drugs which are approved for hypnotic by benzodiazepine. But India, I don't know. I don't think these drugs are not available in India. So triazolam, tamoxifen, ceftazone, fluoxetine. But even though it theoretically say that, but it is not available in India most of the times. I think so. But the onset of action based on that. So triazolam most useful for very rapid. So it's useful for sleep initiations. So suppose this is intermediate acting, this is more useful for my middle insomnia. Likewise, we have to divide based on the onset of actions. And treatment of chronic insomnia, this is nowadays called as Z drugs. You know that this is called as Z drugs because they start with Z, solpidem, solpilone. That's why they call as Z drug. But these are active on the benzodiazepine receptor only, but the different subunits. That's why they call us. But most of the times we see that even benzodiazepine like tolerance and dependent, these drugs also have that side effect profiles. But solpidem and solpidem, they even use for insomnia. After some time, they also they're not able to withdraw easily. So that's our the other side effect like headache, and sometimes even parasomnias were we noted. Most probably we never practice solpidem after using, we have to see sleep wakefulness and so many other side effects we are noted during these solpidem nights. So, but this is also, you have to say that most of the times what the drugs have, most of the times is have only sleep initiation problem. So they have useful for sleep initiation insomnia rather than late onset or middle insomnia because of the shorter duration of action. So nowadays the SR, XR preparation come, which have more of 3 hours. Even then it have only 3 hours of actions. Afterwards they have difficulty. So these zolpidem drugs are, Z drugs are most useful for in sleep initiation insomnia difficulties rather than middle and late insomnias. So chronic other important melatonin receptors. So the melatonin is the usual we call as is like a food. So we don't call it as a drug like. So melatonin receptor, what madam, some MT1 and MT2 receptors are more useful, the melatonin, and they are well tolerated. So the most of the studies say that it's most of the commonly used drug for old age. Prefer benzodiazepines, they have usually, if you write benzodiazepine old age, what the important complications develop, you know that they come for psychiatry, but the next day they landed in orthopedics because the fractures. So they, but not Ramiltons and melatonin receptor agonists have less abuse potential and less leaks. So nowadays the recommended drug for old age, melatonin receptor agonist, Ramilton 8 milligram, but we don't have C efficacy wise, this is less than benzodiazepines. But efficacy wise, benzodiazepine also better drug, but they have a lot of side effects. And madam told that histamine have wakefulness, so we use as antihistamine, doxepines and orexin receptor antagonist, but I don't know whether it's not available in India. Now available. Okay. So we don't have in IMH, so but orexin receptor antagonist, because these also the two antihistamine and orexin receptor, usually histamine and orexin are wakefulness promoting. So we have used as antagonists for that. So that's why doxepine is usually tricyclic antidepressants, but it's a low dose, it's a better use for hypnotic drugs. And orexin receptor, I don't have any experiences, but they can side effect, they can either hallucination, other things. So these are usual drug hypnotic chronic insomnia, but there are other drugs that's usually our benzodiazepine, alprazolam, lorazepam, diazepam. But alprazolam, one of the important drawbacks is very, it's called as dependent very commonly because of the short acting. It's more useful for, they came for addiction probability. Lorazepam and diazepam, lorazepam is an important drug because it have intermediate actions and its metabolites also is not used, it may useful in liver problem also. Lorazepam have no intermediate metabolites, so I can use for patients who have problem with livers and that other thing. Diazepam, one of the important drug, but it's one of the side effect is hangover effect. It's have more long time effect. So hangover is more for diazepam, so it's hangover effect more. So other drugs, metrazepines, very commonly used under trazodone. The two important drugs nowadays because of the high HT1A receptor antagonist. So these two drugs nowadays used for, even though antidepressants, they in low doses, they can use as foreign sedating agents. So metrazepine, we have to use 7.5 milligram, and trazodone less than 50 milligram. They are more useful. And trazodone, one of the important indicator, they can use as a sleep agents for even dementic patients. The behavioral issues itself, they reduce. The dementia with insomnia with behavioral problem, trazodone is one of the important drug to control this. So, and one of the important advantages of trazodone and metrazepine, they have no cetal-like side effect. But one of the important side effect, trazodone have weight gain, other things. Metrazepine also weight gain, and trazodone sometimes have in priapism, so one of the important side effects they have. So these are important points. So if you want to use in old age, either you have to prefer metrazepine or trazodones. Nortriptyline, amitriptyline, you know that again, they are tricyclic, so they have side effect of anticholinergic side effect like urinary retentions and other things for that. And gabapentin, and there are like gabapentin, one of the important advantages, but one of the disadvantages, they cannot able to dose is very difficult. Sometimes not able to adjust the dosage. This is one of the important drawback. Some person will respond about 300 milligram, and some person will respond about only 1200 milligram of gabapentin. So the gabapentin dosage is important drawback, and we know that quetiapine and olanzapine, this is called as nowadays antipsychotic, which have sedating properties. One of the advantages of olanzapine is they have more of appetite stimulant. So nowadays they can use more of cancer patients. So olanzapine 2.5 milligram is more useful in cancer patients also. So that's if you have patients with cancer and sleep disturbance, and they have appetite cachexia problem. Olanzapine, one of the important choices nowadays. So this is why these are the non-pharmacological management. This is more important for an physicians. So stimulus control therapy, sleep restriction, relaxation training, cognitive sleep. So I will only touch upon what is sleep restriction. Most of the times, what is cognitive therapy? You know that. Most of the times, if I have sleep disturbance today, yesterday, then I come to today, what I think that if I have not able to concentrate in my clients, I think that because of only insomnia, I'm not able to concentrate. This is my maladaptive thinking comes. So the CBT, one of the important ways to address the maladaptive thinking pattern. Then I either, if I do everything correct, so like all or none law. If I have good sleep, only I do things good. If I have bad sleep, I'm not able to think good. So this is called as on or none thing phenomena. So people with CBT will address these. Then the people will know that. And maladaptive pattern of thinking that I already told that I'm not able to sleep. That's why I'm fatigued like that. So I attribute everything to my sleep problems. So this is the cognitive behavioral therapy. Sleep restrictions that I will store that's why sleep efficiency is more than 85%. What is sleep restriction therapy in chronic insomnia? For example, if I go for bed about 11 o'clock, but I sleep only at 2 o'clock, I get up in the morning at 7 o'clock. But my total bedtime is 9 hours, but my sleep time only 6 hours. What is do on sleep restriction therapy? You reduce, so it's needed sleep diary. For example, I want to go to sleep restriction therapy. I write my sleep diaries for 2 weeks and I average to calculate my total bedtime and sleep time. So sleep restriction means I cut short my bedtime. For example, I go to 11 o'clock, but I sleep only 2 o'clock. So I cut short my 11 to 12. I go only bed by 1 o'clock only. That is called the sleep restriction. But initially, it's very difficult for the patients. Patient already told that I may have very chronic insomnia. How we do that? But after 3 weeks of training of sleep restriction therapy, our sleep efficiency definitely improve more than 85%. So important therapy, when the other treatment are failed, you can go for sleep restriction therapies and stimulus control. You know that already, you know that I go to bed without any mobile and everything. And most of the time people always clock in the bedroom. This is a very hindering effect. I always see, I go to bed, 11 o'clock, I'm not able to sleep, 11:30, 11:45. So this is a clock in the bedroom. So I advise the patient who are chronic insomniac, you remove your clock from your bedroom. First thing. So that is an important factor to come out of the arousal mechanism. Otherwise, I always see the clock, I become panic. So one of the important stimulus to control, and I create a bedroom where only, that's why I told, bedroom, if I have a person with insomnia, they go bed only for sleep. They don't do any other activities. If they do their activities, the brain will associate, you know, the classical conditions. So it's become associate. And one of the important factor to always go to bed only you feel sleepy. Most of the time people go to bed and try to sleep. That is important factor will antagonist. We go to bed and try to sleep, our anxious become overactivated. You cannot able to sleep. So you have to go to bed only you feel sleep. This is the first step in insomnia patients. And always get up the same time. The second important point. If you're not able to get up the same time, for example, I go to bed today 9 o'clock. Tomorrow I go to bed at 10 o'clock. So that's why I get 7 o'clock, 8 o'clock. Never do that. Always get up in the same morning. And as much as possible, morning dim light. That's what madam told, that morning sunlight, one of the important factors to night stimulus of sleep. Because the melatonins and everything, if you go to in the morning sunlight, that will create night melatonin secretions. And as much as possible, coffee and alcohol, avoid after 6 o'clock. You don't take coffee and alcohol, everything, and even smoking, and heavy exercise in the night. Usually after 7 o'clock, we don't do heavy exercise. You have to do exercise, especially in the afternoon or in the morning time. That's why I do yoga, important exercise. That's important to have these stimulus control. And you other things, relaxation technique. That's more important. Yoga, one of the other important relaxation technique. You have to do yoga. And sometimes people very busy, they not even do yoga. So what can you do? Your breathing exercise. Nowadays, there are a lot of breathing exercise come to play. Even box breathings. We call it as namesake, we call it as box breathing. And usually we are chest breather. But you have to shift our breath to belly breathing itself cause relaxations. You know that belly breathing, because belly is the area where our vagus are there. So the vagus, it will create more of parasympathetic activity. So hyperarousal is a state of sympathetic overactivity. So we have to shift to belly breathing. Automatically we become more of parasympathetic activity that itself create a smooth relaxation. So whenever you go bed, you cannot even sleep. You close your eyes, watch your breath. That itself created some relaxations. So with this, I will conclude. I think so. Thank you so much.
Thank you, sir, for sharing your years of clinical expertise and experience with all of us. It will be like, I think the audience will treasure this. What I would want to highlight here is gradually how SAR has progressed from approaching the patient, first establishing that whether insomnia is there, then ruling out the medical causes, then checking whether there are secondary causes for that insomnia. And while treating also, we should make sure that benzodiazepines are not the first choice. You can give, when giving benzodiazepines, it has to be not more than 2 to 3 weeks or so. After that, we can use medications like antidepressants and antipsychotics with sedative potential and taper off the benzodiazepines. We have seen patients with 90 tablets of alprazolam in the morning and night. And alprazolam, if the audience are somebody are able to take home message that please avoid alprazolam, Anxit, Trica. So these are the common brand names which are continuously there, prescribed by many physicians. So now the problem is it's having such a short half-life that the person gets addicted and tolerance develops very fast. So thank you. And the most important thing would be the non-pharmacological managements which Sir had mentioned. Many a times those are the reasons. Thank you, sir. Thanks a lot. Any queries? These are practical things which Sir has discussed. Anything you want to ask a query to him? It'd be nice if any of that.
Yes,
Yeah.
In a group, a person asked about role of avoiding blue light and use of warm LED light in evening hours for chronic insomnia. Is it really worth the investment in changes in evening hours illumination? Role of avoiding blue light and use of warm LED lights in evening hours for chronic insomnia. Is it really worth the investment in changes in evening hours illumination?
But studies say that definitely blue light has some impact on insomnia. But there is no comparative study with warm light and this light. That's why I don't know the answer. But we big expert, they have some answers they can tell.
I mean, usually the warm light and sometimes the red light is also suggested nowadays for improving sleep. But the main thing is you avoid the screen time itself, it will work. We have studies coming up for red light and orange, I mean, dim light and all. It helps during sleep time. So that can, see, it's not much of an investment. It's just the different color of a bulb which you can use. That there has been some evidence that it might work, but avoid the mobile time. Avoiding the mobile giving you notifications. Switch off the notifications in your apps. You have many people should know that in the settings there is parental controls or digital controls. You can set the number of time limit, the number of Instagram time and things, and after maybe 9:30 or 10, the mobile will not work apart from emergency. So these things will actually. Any other doubts?
The role of melatonin therapy.
The role of melatonin, that's why we say that melatonin is like a food. So we can use melatonin, but the efficacy is not, I don't know, and we have to give certain amount of time before that, at least minimum 1 hour to half an hour with blood, but that definitely have impact on sleep, definitely. Sometimes effectiveness is not there, but not proven. So we start with 3 milligram of melatonin and gradually increase up to 5 milligram. But is not there. The melatonin receptor agonist is more potent than melatonin. Studies say that. A lot of journals and articles say that potent is more than MT1 receptor agonist rather than melatonin per se, because it's not like an actual substance. Already person suffering from insomnia. But we don't have any experience between melatonin and melatonin. But studies in most of the world say that melatonin has more potent than melatonin per se.
So the one other newer medication is lemborexant. The orexin receptor one, pretty costly, 80-85 rupees per tablet. Lemborexant. So now they claim that the falls problem, cognitive deficits problem are all relatively less. We have used in few patients. When the side effect reduces, we have to be pretty careful whether the actual effect comes or not. So that's why for hardcore insomnia patients, melatonin doesn't work. You have to initially give benzodiazepines, then gradually taper off, replace it with antidepressants or antipsychotics with the sleep tendency. Best thing that works will be non-pharmacological. Anything else?
Thank you, Dr. Venkatesh Madan Kumar, for your insightful presentation on approach to insomnia. Your discussion of the complex relationship between insomnia and the psychiatric conditions are invaluable. Your clear breakdown of the clinical approaches to diagnosing and treating insomnia will undoubtedly enhance our clinical practice. The depth of our knowledge and the way you tied the physiological with the psychological aspects of sleep disorders is greatly appreciated. We look forward to integrating these strategies with our practice to better manage this common yet challenging condition. I now request Dr. Kailash Suresh Kumar to kindly felicitate Dr. Venkatesh Madan Kumar for his excellent contribution. Okay, but speakers will be felicitated after speech. No, it's very using for don't like that. We will now take a short tea break. Please use this time to network and interact with fellow participants. The formal inauguration will follow immediately after the break. Everyone, please wait for a few minutes. Okay. Dean is coming to the conference also. Please wait for a few minutes. We'll have tea break after the inauguration. Oh, who's that? Sasi Kumar sir, Dean is? Okay. Anand sir is left. Okay. Anand. Five. Kumar sir, Manoharan sir, Veerababu sir, Priya ma'am.
This one.
Oh, he's sitting on the back.
This one. This one.
All Sarada. It is my great privilege to welcome you all to this auspicious occasion. As we gather here to explore the multifaceted nature of sleep, I would like to extend a warm welcome to our esteemed guests and dignitaries, those whose presence makes this event even more special. To begin this special session, I would like to invite our esteemed dignitaries to join us to the dais. Dr. P. Sasikumar, Dean, Sri Balaji Medical College and Hospital. Dr. D. Manoharan, Medical Superintendent, Sri Balaji Medical College and Hospital. Dr. Veera Babu, Medical Advisor, Sri Balaji Medical College and Hospital. And Dr. Priya Shivashankar, Professor and HOD of Department of Psychiatry. Please join me in welcoming these distinguished dignitaries with warm round of applause. Let us now raise for rendition of the Tamil Thai Varthu, honoring our rich Tamil heritage and culture. Lamp lighting ceremony. The lighting of the lamp represents the dispelling of the darkness and the pursuit of knowledge. I now request our dignitaries and speakers to step forward for the lamp lighting ceremony, officially inaugurating the conference. Inauguration. It is my privilege to invite Professor Priya Shivashankar, Professor and Head of the Department of Psychiatry, to deliver the inaugural address. Professor Shivashankar has been instrumental in organizing this conference and is a respected leader in the field of psychiatry. Her leadership has been crucial in shaping the vision of the department and bringing together this esteemed group of professionals and experts. Over to you, ma'am.
Good morning. Good morning. A very warm welcome to the dignitaries on the stage. Dean Sir, Dr. Sasikumar, Advisor Sir, Dr. Veerabahu Sir, Professors and HODs of other departments, respected speakers and respected chairpersons, and other delegates. This conference was conceptualized because today is the International Sleep Day, and we thought there is no better way of imparting knowledge and information about sleep than organizing a conference that covers various aspects of it. Sleep is important for mental functions. It helps us to de-stress. It helps us to process our emotions. It is very important in memory and regulation. So, along with that, it also has a lot of important functions for the body. It is good for immune functions. It has a lot of information about the respiratory system, along with other metabolic things. So we have put together this speech, this conference. We started off with the physiology of sleep, where we understood what are the stages of sleep, how one falls into sleep over through the various stages, what are the brain structures and the chemicals that are responsible for it. And Devaki ma'am gave us a very nice comprehensive lecture to those who are interested about sleep. Next, we have insomnia is a very common medical problem, psychiatric problem as well. Patients often come to us saying, I'm not able to sleep. Only with the proper history, mental status examination, questionnaires, as well as investigations, we come to know what the diagnosis is. So Venkatesh Mathan sir helped to clarify about the clinical aspects of insomnia. Our next speech is moving a little more toward the psychiatric aspect. Dr. Deepa will be talking about the sleep patterns and various psychiatric abnormalities. This will help us all as clinicians to understand how a person presents and how we can do, or what we can do to help them. After this, we have a pulmonologist, Dr. Benhur, speaking. He will be talking on a very common topic, that is obstructive sleep apnea. This is responsible for a lot of daytime drowsiness and cognitive difficulties presenting in middle-aged or older people. So his speech is going to help us to address that issue. And our international speaker is going to be talking about polysomnography, which is an investigation for sleep and sleep-related disorders. So with these speeches, we hope that we will enrich our knowledge about sleep. Thank you very much for attending. I forgot to extend a hearty welcome to a lot of participants who are available online. So there are participants from Jammu, Haryana, Punjab, as well as Andamans, not to mention the common southern states of Karnataka, Kerala, and Andhra. Hearty welcome for all of you, and I hope you have a great understanding of sleep medicine today. Thank you.
Thank you, ma'am. Next, I would like to invite Dr. P. Kumar, Dean of Sree Balaji Medical College and Hospital, to address the gathering. Dr. Kumar has always supported initiatives that advance medical education and mental health care, and it is under his leadership that this institution has continued to excel. Please welcome, sir.
Good morning, everyone. Respected advisor, Dr. Priya, HOD of Psychiatry Department, faculties of the Department of Psychiatry and other departments, and my dear students and the people who are delegates who are joining online also. I extend the morning wishes to all. And it's indeed a big honor and pleasure for me to be part of the inaugural ceremony of Sleep 360, the international conference, international hybrid conference conducted by the Department of Psychiatry. First of all, I take this opportunity to congratulate the organizing team headed by Dr. Priya Sevashankar and the department faculties for organizing such a wonderful conference. As she said, she's covered all aspects of sleep. And nobody would be appreciating sleep. Only people who are not having proper sleep only will know what is the importance of sleep. People who sleep off will don't know about it. People who struggle to sleep even at 4 o'clock in the morning or anything, they'll know what good sleep means. And definitely a good sleep gives you good energy to work in the morning. When you have a good night's sleep, whatever it is, not necessarily a good night's sleep. Even nowadays we say, as a surgeon, I know when I go to a theater and the anesthesia is late by 10 minutes, now I'll lie down on the couch and try to sleep. And that 5 minutes sleep also gives you such a wonderful, refreshing energy and clarity of thought. And you feel recharged sort of thing, and it makes you work better. So definitely sleep, and all the aspects of sleep and disorders, everything will be covered today. And I take this opportunity to thank and welcome the speakers, Dr. Devaki, Dr. Venkatesh, Mathan, Kumar, Dr. Deepa, Gopinath, Dr. Benhur, and Dr. Boobala, Aravinthan, for accepting our invitation and accepting to be the speakers in this conference and sharing their wide knowledge about the sleep to the audience. I hope all the faculties who are going to delegates who are going to attend this conference will be rich by knowledge with all the experience shared by them. And I hope this conference is a great success. Thank you very much.
I now request Dr. Veerababu, a medical advisor, to share a few words on our today's conference.
My dear colleagues, good morning to everyone here. I am very happy here to be a part of you to listen rather than to talk, because this is a very novel topic, very sleepy topic, very interesting topic, unusual topic. I was congratulate Priya having taken this topic of sleep. Mythologically, I understand Kumbhakarna was sleeping all the times, no time. And I want to know how can he sleep? I think I should ask that question to the great people who are doing Kadakala Shevam on epic Ramayana and Mahabharata. I think they should have some answer for his sleep all the time, something going on in the brain for him. That's what I think. But today, the sleep is so good, so important, as Professor Satykumar says, sometimes sleep is welcome. Even the 5 minutes sleep is a pressure, relief. And you should appreciate sleep when you work very well. You work very well, you can appreciate sleep. And you don't work well, you can't appreciate sleep. And I think today we are going to learn so much of sleep. And I once again congratulate Department of Psychiatry, our very Priya and her colleagues having brought this topic to know something about it. Thank you very much. I wish the conference goes on very well and we learn more and more. Thanks.
Thank you to all our dignitaries for their inspiring words and for gracing this occasion with their presence. With that, we conclude the inaugural session. Now I invite all our chairpersons and speakers to this dais for a group photo. I request everyone to proceed for the tea break, which is served just outside the hall. Please assemble promptly for the next session. Thank you. We will reconvene for the session on sleep patterns and psychiatric disorders, chaired by Dr. Kailash Suresh Kumar once again. Dr. Suresh Kumar, we welcome you to the dais for introducing the speaker.
Yeah, no, outside I'm thankful to Dr. Priya and Dr. Gopinath to give me a second opportunity to chair a second session, and that too with my colleague. We were working together in Enhance, me, Dr. Gopinath, and Dr. Deepa. So very happy to have Dr. Deepa Gopinath. She is a consultant psychiatrist in Chennai Mind Care and also in Kaveri Hospital. She is a profound academician. She has received a lot of research awards. She has secured a prize of Young Researcher Award in Icons Scarf in Chennai. And she has received an educational grant to attend the 12th World Congress in Biological Psychiatry in Athens. Best Poster Award in National Conference on Maternal Health and Motherhood in NIMHANS, Bangalore. So I welcome you for the talk. It's such an interesting topic because different psychiatric disorders, depression, anxiety, bipolar, schiz, everything has a very different neurobiology and all have their own imprint or stamp on the sleep pattern which a person has. Many times this also helps us as a diagnostic aids in our diagnosis that it could be the possible diagnosis and also helps us in treatment. I welcome Dr. Deepa Gopinath for her.
Very audible. This one.
This one.
Oh, okay. Oh, okay. Oh, okay, fine. Very good morning to all of you present here. I would like to extend a heartfelt thanks to the Department of Psychiatry, Balaji Medical College for inviting me as a speaker. So I'll definitely take a minute to say that they've always been very warm and welcoming to me. Everyone in the department, it's half home for me. And I really want to thank them for speaking with Sir Kailash sir as chairperson, because Sir said he had been our beloved senior resident at NIMHANS. So we worked long and close at NIMHANS. And it is also an honor to share stage with Dr. Venkatesh sir. Sir has been my professor in Stanley and UG. So after 20 years to share stage with you, it's really an honor, sir. So with that, let me just start off. So my topic today is sleep patterns in psychiatric disorders. So this is a brief outline. So I'll take you through all psychiatric disorders and the sleep patterns and briefly way ahead. So to begin with depression. Now sleep issue, insomnia is very, very common in depression. About 80% suffer from insomnia. At the same time, 15 to 30% of the people suffer from hypersomnia as well, excessive sleepiness as well. Now, the sleep EEG finding. Now, we have a very strong base with what Professor Devaki ma'am spoke in the morning about normal sleep EEG. So, these are the findings. We'll be seeing the hypnogram as well. So, there is an impaired sleep continuity,
in terms of there is a prolonged sleep latency, taking time to go to sleep, increased intermittent awakening, early morning awakening. There is a disinhibition of the REM sleep. So there is a very the shortened REM latency, which usually is about, let's say, about 90 minutes or so. It's reduced when it comes to depression. And sleep on prolonged first REM, the first REM period is prolonged. There is an enhanced REM density in the first half of the sleep cycle. There is also change in the non-REM, where ma'am was mentioning about how important the deep sleep is. So there's a gross reduction in the deep sleep, the slow wave sleep, when it comes to depression. Now, this is the hypnogram. So like what ma'am had also depicted, that was for the normal, healthy control. This is the typical sleep. The second one shows a person with depression. So you can see that the time taken to reach REM sleep is quite short here. So the REM latency is short. At the same time, the REM duration is quite long. And the short wave sleep, the deep sleep is quite short when it comes to depression. Now, I'll also add a word on antidepressants. So when we are talking about the disorders, the respective disorders, we'd also like to learn about what the medicines do to the sleep. So SSRIs and SNRIs, which are so commonly prescribed when it comes to depression, they have a role in REM suppression. And REM suppression plays a very important role in remission of depressive symptoms. So they help in REM suppression. They also increase the REM latency. We saw that the REM latency was decreased in depression. So they increase the REM latency, SSRIs and SNRIs. Now we know the very sedating antidepressants, mirtazapine and trazodone, are very commonly prescribed for sleep issues. So even for insomnia, even in the absence of a depressive disorder. So trazodone, mirtazapine decrease the sleep latency. So they help in inducing sleep, and they increase the short wave, the slow wave sleep, which is the deep sleep. Tricyclic antidepressants like imipramine and amitriptyline, they also decrease the sleep latency. They also have a role in REM suppression, and they increase the REM latency, like the SSRIs and SNRIs. It's not going to the next slide. Okay. So this was a study which looked at treatment emergent insomnia cum hypersomnolence when started on antidepressants. So in SSRIs and SNRIs, what we see is people who were started on venlafaxine, when compared to the other SSRIs and SNRIs, reported more of insomnia after being started on the drug. And when it comes to other antidepressants, insomnia, we are very aware of bupropion being such an agent, which is why we prescribe bupropion in the mornings, because it can lead to insomnia for some people. Treatment emergent somnolence, like we discussed, mirtazapine and trazodone have quite a role in, we use them for their sedating properties, so they can cause treatment emergent somnolence. Now, I'm adding about antipsychotics here because many of us also prescribe antipsychotics in cases of depression, even in unipolar depression. So be it typical antipsychotics or atypical antipsychotics, they increase the total sleep duration. They improve the sleep efficiency. Like what Sir was saying, sleep efficiency is the time that is spent sleeping when compared to the time that is spent on bed. So how long and efficiently you are sleeping. So it's not only about time spent on bed, time spent sleeping divided by the time spent on bed into 100. That is sleep efficiency. It is seen to improve the sleep efficiency, both typical and atypical antipsychotics. Atypical antipsychotics seem to have a role in the deep sleep as well. In the slow wave sleep, they increase the slow wave sleep. Now, treatment emergent insomnia. So I'm not talking about somnolence here. Most of the antipsychotics are sedating, but exceptions are aripiprazole. Again, sometimes we have to prescribe it in the day. So aripiprazole, acinapin, and lurasidone are the antipsychotics that are found to cause sometimes treatment emergent insomnia. The rest, all other antipsychotics are known to be sedating. Now, important thing here when it comes to sleep. So when we talk about affective disorders here, I'm also meaning bipolar disorder and unipolar depression. high risk probands have been studied for many things to have a better understanding. So here they are people who have not yet developed a disorder, but they have a high family loading of people with affective disorders. So these high risk probands who are actually healthy now were found to have an enhanced REM density, which we saw in depression, and a reduced time spent in the deep sleep, the non-REM. They also, and so elevated REM density could also be a valid biomarker in for depression and for affective disorders. This is also found to have a high predictive value for those, again, in probands who could develop an affective disorder. So these probands were studied. In 4 years, quite a high percentage of them had developed one episode of an affective disorder. Then they were studied 10 years later, and many more had gone on to develop affective disorders. And the sleep issues are found to be associated with a poorer outcome in both patients as well as probands. Now, talking about schizophrenia, again, disturbed sleep is a very common complaint in schizophrenia. It is again a predictive symptom. So someone who is probably in a prodrome. Now, someone who has a sleep disturbance, quite likely they will turn into psychosis sometime later. So this is also related to the disease severity. Someone having a sleep issue could be later having a severe psychotic symptom or severe disease. It is also related to deficits in cognition. We understood from ma'am in the morning how important each phase of sleep is with respect to learning and memory. So they are those with a sleep problem have deficits in cognition and learning. Again, increased risk of suicide attempts, like sir had mentioned previously, quite linked to a sleep disturbance. Poorer quality of life. So quality of life is measured in terms of physical health, psychological well-being, and social relationships. So on all these domains, they scored low, someone with a sleep problem. Now, there's also a higher occurrence of periodic limb movement disorder, restless leg syndrome, and obstructive sleep apnea, the other sleep-related issues in someone with schizophrenia having a sleep disorder. And those with restless leg syndrome are found to have higher anxiety and depression. So I'm just taking this opportunity to talk about the differences, could be of academic importance to PGs. So the difference between akathisia and restless leg syndrome. So the prevalence of akathisia is far higher than restless leg syndrome. Gender prevalence wise, restless leg syndrome is more common in women, and motor restlessness is present in the restless leg syndrome, whereas not so much seen in akathisia. Paresthesias are seen more in restless leg syndrome. And we know that restless leg syndrome happens mostly at night, whereas akathisia can happen anytime during the day. Sleep disturbance is absent in akathisia as such, but it is very much present in restless leg syndrome. Lying down aggravates it when it comes to restless leg syndrome. Myoclonus could be present in very severe cases in restless leg syndrome, and the treatment varies. So akathisia we treat with beta blockers, anticholinergics, whereas restless leg syndrome we treat with dopamine agonists. Now, antipsychotics were, this study studied antipsychotics causing obstructive sleep apnea. So the stop bang questionnaire was used to see how they have, how each antipsychotic influences one's tendency to develop obstructive sleep apnea. Clozapine was found to have 85% risk when compared to risperidone 70%, olanzapine 35%, flufenazine 25%. Now, bipolar and sleep. Of course, we know how important it is. We psychoeducate our patients, their families about the importance of sleep. No matter what, sleep cannot be compromised when it comes to bipolar disorder. Now, non-adaptive circadian system seems to be a marker. Now, we see a lot of people are working in the night shift. Lot of people are working in the night shift. Lot of people, if not in the night shift, have jobs that extend till way long in the night. Now, an affective disorder does not necessarily affect everyone. So, but someone who's not able to adapt to this change in the circadian system could be at risk for an affective disorder. So this is the meaning of a non-adaptive circadian system, which could be a marker for bipolar. It is an important marker for relapse as well. The clock gene seems to be implicated here. Poor sleep affects cognitive functioning, as we have already seen. Now, there is cognitive behavior therapy that has been tailor-made for insomnia, with a lot of things that Sir had mentioned about sleep restriction, stimulus control, and things like that. So this CBT seems to be improving sleep quality, sleep onset latency, sleep efficiency, and the total sleep time. Now, in unipolar depression, like what we've already seen, just a recap of it, reduction in the slow wave sleep, say REM sleep, disinhibition, REM latency, increased REM density. These are all the changes that we see. Now, in bipolar depression, what is a differentiating factor is very fragmented REM sleep. This stands out separately. So, a very fragmented REM sleep, longer sleep onset latency, increased number of spindles, greater percentage of awakenings, and greater REM density. So that is about bipolar depression. In mania, again, there's a disruption in the sleep continuity. There's a reduced REM latency, heightened percentage of stage 1 sleep, and increased REM density. In euthymia, surprisingly, many studies have studied people when they've been euthymic, when they have remitted from an episode, way after their episode had been, let's say, 1 year later, 2 years later, they continue to have a longer sleep onset latency, increased awakenings during the night, increased REM density, and a decreased sleep efficiency. Now, anxiety disorders. So, all the anxiety disorders have one sleep issue or the other. Either it's insomnia, either it's hypersomnia, or it is a combination of both. So there is a problem with sleep maintenance and a reduced REM latency. Now, this is a coefficient plot, and what we see here in general, the more the generalized anxiety disorder which is seen here seems to be more related to insomnia, associated with insomnia, fatigue, and a non-restorative sleep. Ma'am had spoken about the importance of a restorative sleep in the morning. So a restorative sleep is a rejuvenating, refreshing sleep, which one lacks when they have a generalized anxiety disorder. Similarly with OCD, where it is again related to insomnia, fatigue, and a non-restorative sleep. Social anxiety is also associated with insomnia, fatigue, and a non-restorative sleep, poor sleep quality. Now, PTSD is a very important disorder to be discussed here. So, sleep seems to be playing an etiological role as well. So, what they say is someone who has been having a sleep issue for long, a non-specific sleep issue for long, they undergo trauma. They are much more at risk to develop a PTSD when compared to someone who has had a normal, healthy sleep before trauma exposure. So, sleep seems to be playing an important etiological role. There is a reduced gray matter volume in the ventromedial prefrontal cortex, which is related to the chronic insomnia. The reduced gray matter volume in amygdala, hippocampus, anterior cingulate cortex, and insula is related to the nightmares in the PTSD. Now, the REM sleep disturbance is a major finding there. REM is important for memory consolidation and affective processing. So, and there is increased, when they did these glucose metabolism imaging studies, there was increased metabolism in the brainstem, limbic system, and striatum, both during waking state and REM sleep. So, that is associated with the intrusion and avoidance symptoms of PTSD. So, sleep disordered breathing is also seen. Obstructive sleep apnea is seen in many with PTSD. Now, again, CBT tailor-made to PTSD, where there is fear memory exposure and they are taught how to do the emotional processing, how to rework on their emotional processing, along with an SSRI seems to be helping PTSD. If there is an incomplete resolution of, because we are talking about sleep here, so if there is an incomplete resolution of the sleep symptoms, it could definitely interfere with the CBT. EMDR, which is very popular for PTSD, has been found to be effective in the sleep fragmentation symptoms. And of course, CPAP could be used for obstructive sleep apnea. Eating disorders, with what has been studied so far, there are not many findings when it comes to bulimia nervosa and binge eating. But anorexia seems to have a reduced sleep duration, and there is a more fragmented sleep. So which means it's a less restorative sleep, less rejuvenating sleep, and a decreased sleep efficiency in anorexia. Substance use disorders. So sedative hypnotics, cannabis, and cannabis related drugs and alcohol have all been used to induce sleep. So alcohol, like sir was also saying, that initially it induces sleep, but then there comes the hyperarousal. So when either in be it withdrawal or prolonged usage, amphetamine or cocaine have been used as stimulant drugs, and sleepiness is found when the person abstains from the drug. Now, what is important to assess here is whether the person is using it as therapy. You know, they have an underlying mood problem, they have an underlying anxiety, they have an underlying sleep problem. So, are they trying to self-medicate with any of these? So, is it therapy seeking or is it drug seeking? They are, you know, it is just the euphorogenic effect of the drug. So, that is important to determine when we are assessing the client. Now, personality disorders, again, a lot of studies have happened more with the cluster B personality traits and personality disorders. Now, this is about borderline personality. We know the four major domains of borderline personality: interpersonal sensitivity, affective dysregulation, impulsivity, and of course, we say mindfulness, but then let's say these are the three core symptoms of borderline personality. So, each of these mediate through various mechanisms to make sure one has a sleep issue very similar to what one sees in depression. So again, this is the coefficient plot for emotional dysregulation and emotional instability, very commonly seen in cluster B. So again, quite linked to insomnia, fatigue, and a non-restorative sleep. Impulsivity also closely related to, the closer it is to the midline, it is not so related. So impulsivity wise, there is no major correlation with insomnia, fatigue, and a non-restorative sleep. Now talking about special populations. So when it comes to a child, a few prerequisites are needed for a normal healthy sleep. So a very secure attachment that a child has at home, a very happy family where the child grows up, and any absence of an internalizing problem generally promotes a good sleep in children. Now, nightmares are very frequently observed in children. 80% of children in the age group of 4 to 12 report of nightmares. Now, frequent nightmares, which is like once in a week or so, are seen in only about 15% of children. When it comes to the younger 4 to 8 age group, they are they talk more about imaginary creatures. The 9 to 12 age group often have nightmares of getting kidnapped, and most of them say that the content they have is more what they have seen on television or any content that they have otherwise seen. Repetitive nightmares can be a hallmark. You can definitely suspect trauma in the child. ADHD, very common, again, very common and very common to have sleep problems in ADHD. So there is a disruption of the circadian rhythm. When they come to you as adults also, they tell you, I never recall having slept well even as a child. Very light sleepers. So most of them have a sleep problem. Now, increased sleep disordered breathing and restless leg syndrome are more seen in children with ADHD than adults with ADHD. So that is important. So again, ADHD is related to insomnia, fatigue, and a non-restorative sleep. Pediatric OCD. So 6 out of 9 adolescents with OCD have a significant sleep problem. They have a significantly shorter total sleep duration, non-REM sleep, and a decreased REM latency. CBT with SSRI improves the sleep as well. Pediatric depression, sleep complaints are again very common. 25% of adolescents will talk about hypersomnia as well. 10%, like we discussed about bipolar, continue to have sleep symptoms even after remission of the episode. Hospitalized psychotic patients and suicidal patients have a significantly longer sleep latency, reduced REM latency and increased REM time when compared to their non-psychotic counterparts and OP treated counterparts. Pediatric bipolar, again, 40% have a decreased need for sleep. We often use the term decreased need for sleep. A very close differential would be ADHD when it comes to pediatric bipolar. But the decreased need for sleep is reported in only 6% of children with ADHD. School refusal. A disturbed circadian rhythm, delayed sleep phase is quite common in a child with school refusal. That in turn is related to, so that gives rise to somatic symptoms, which increase in severity and frequency, which further promotes school refusal. So this study tried to administer 1 to 10 milligram of melatonin to the children. But what was found was only the sleep-wake cycle improved, but they did not end up going to school. Autism spectrum disorder and PDDs. So again, many report sleep problems. Now, what has to be noted here is, this is parent-reported sleep problem. The child is not telling you that I have a sleep problem. Why I'm emphasizing this here is, I saw the coefficient plot of autism. Very few have, because that is done with sleep EEG. Very few have actually had sleep issues that way, significant sleep issue that way. So the interpretation is that parents are very, very sensitive to even small movements when it comes to this, this category of children. So the parent-reported sleep problems are more when compared to objective finding. There's a delayed sleep onset with slow sleep, with a low sleep efficiency. REM behavior disorder is again commonly found in autism. So there seems to be a neurodegenerative theory there, which of course we read about. So REM, it is commonly encountered. Chronotherapy, which we'll find in the in literature with respect to ASD, it refers to altering environmental and social cues to achieve a shift in the child's sleep phase. So when there is an improvement in sleep, we see that there is an improvement in the daytime behavior. So trauma, the first thing that gets affected when a child is exposed to trauma is sleep. So there is a difficulty in initiating sleep, there is excessive arousal, frequent nightmares. So what happens is, children, when it's a very quiet surrounding, daytime, it's in the dark, they tend to re-experience the trauma in the night at bedtime. And what they also say is, very often, if it is a, let's say, sexual abuse, like Sir had also mentioned, associative learning is very strong. So when they see the dark, they see the bed, they are reminded of trauma. So it then becomes a very tedious process for them to go to sleep. So this is and what we see again in trauma is, initially it causes insomnia. So initially children report of a sleep disturbance, but as it goes, and when like untreated or with not great treatment outcomes, it goes to hypersomnia. They tend to sleep more. They basically shut off completely. Substance use, again, we should be talking more about it. No taboo anymore when it comes to adolescent age group. I think we need to educate them a lot. So there is a dose-dependent relationship between smoking and sleep issues. Those who smoke more seem to have more of a sleep problem. Now about the geriatric age group. So the total sleep time, sleep latency, slow wave sleep, REM sleep, everything decreases across adulthood. This starts right from the 3rd decade of life. But only sleep efficiency, as such, which we spoke about, seems to significantly decrease after 60 years of age. This is associated with a greater medical morbidity. Now, these circuits were something that were already spoken about. What is important is the suprachiasmatic nucleus, which is the pacemaker, which is the main area for the circadian rhythm. So there seems to be an internal degeneration that happens with age. Now, 70% of those with early stage dementia have a sleep problem. It is predictive of poorer outcomes, be it cognitive and neuropsychiatric. 70 to 80% of them have obstructive sleep apnea. And we see that obstructive sleep apnea in the healthy elderly also leads to earlier onset of mild cognitive impairment and dementia. So what happens in obstructive sleep apnea is basically hypoxia. So acute hypoxia increases tau phosphorylation, Chronic hypoxia increases A beta formation, plaque formation. Another mechanism that is explained is the glymphatic system. This is basically a waste clearance system, and the waste is circulated between the CSF and the interstitial fluid. Now, what happens with age is that this circulation comes down. So basically, the waste, the toxins start aggregating, and a lot of A beta starts aggregating. Sleep is found to help in the clearance of this of the A beta. So when there is a sleep disturbance, the A beta starts accumulating. Now, in the Parkinsonian dementias, like we know, REM behavioral disorder is very common. So it's what they say is, like, we know in the REM sleep there is supposed to be a muscle paralysis, but then the lack of that is where they enact what they dream. That is REM behavioral disorder. But it is important to confirm this with a polysomnogram, because sometimes they could be enacting in the non-REM as well, which cannot be taken as pathological. Benzodiazepines are used for management. 50% of those with just a REM behavioral disorder already start exhibiting signs of Parkinson's. So this is basically sleep issues are treated with mirtazapine, trazodone, and benzodiazepine. Sleep disordered breathing has also to be managed accordingly with CPAP. Now, any presentation is incomplete without AI. The disclaimer: this presentation is not AI powered, but then we need to definitely, because 10 years later, the practice is definitely going to change. If we don't update ourselves, we'll be left behind. So already, you know, there are a lot of devices that people use. And the flip side of it is that a lot of people come to the clinic saying, my watch says I'm not sleeping well. So now I've gone through all the tests, and I've gone through this, I've gone through that. So, but we've just started when it comes to sleep medicine. And what I read was a lot of work has happened in obstructive sleep apnea. So they found ways of integrating information, making procedures less tedious because of AI, and made it a little more easier to diagnose obstructive sleep apnea. But otherwise, other sleep pattern disturbances, we can monitor with the devices that are already available. And there's a lot more that needs to be explored when it comes to AI. So with this, I end my presentation. Thank you so much.
Thank you for an exhaustive presentation, Deepa. You started with the usual major psychiatric illnesses, depression, anxiety, bipolar. The child psychiatry part of it as a section was very interesting. So, any questions, any queries from the audience? Please be open. Is there any question in the group? Yeah. Go ahead. Can somebody go ahead?
Query which I face in my clinical practice. What happens is, if a patient is having bipolar disorder and we are maintaining in remission, but they have they go to sleep at around 1 o'clock, and then they wake up at around 8 o'clock, they are able to function properly. So should we address this?
See, that is where the delayed sleep phase sleep that even was spoken about earlier. We have to understand this individual. There is no dictum. If that has predicted, that has been a signature symptom sometime, you know, in the beginning of an episode, then this routine is definitely not okay. I would generally not recommend that sleep for anyone, particularly with an affective, be it unipolar depression or bipolar. Certainly nothing to do in the night, you know, but even if it is 1 o'clock, I would rather tread cautious. because we know that sleep deprivation could bring on a relapse or some subsyndromal symptoms. So best would be to counsel them to avoid such a job or any such.
In most situations, waking up is in our hand, no? So maybe the delayed sleep phase you can prepone. Ask them to wake up 1 hour before, hoping that they'll go for sleep again. Increase physical activity. Maybe some amount of melatonin can help. These are the two ways.
Thank you.
Thank you, Doctor. It was a very wonderful presentation. Nowadays, I think we see a lot of people with anxiety disorder. They come reporting like, I'm getting dreams. It is not like night terrifying dreams or normal dreams, but still they attribute, okay, that is, they try to say that my sleep was not that great. So can you help with that? And unfortunately, that is becoming retroactive also because dream is a part of the sleeping process itself. Like though we try to explain it, however, people try to, but we can understand like the lot of associated factors that you quoted with various anxiety disorders. So how to handle such situations? Like people saying that I'm getting dreams, that's why my sleep is not that great.
So first would be to extensively reassure the client that, okay, this is part of a normal process that you're going through, and if you don't process it any further, you're fine. But then if we see that practically speaking, this is affecting their sleep quality and hence their daytime functioning, a very low dose of trazonil or mirtazapine kind of a medicine could help, which is again like non-benzodiazepine, but at the same time will improve the sleep quality.
That's a very valid question. I had also published a paper on dream anxiety. This dream anxiety is such a troubling complaint. You can give medication to, if there's less sleep, you can give. But these patients say that my dreams are so real that I feel that it's actually really happening. And sometimes it's many patients report that it is almost like my day-to-day things are itself repeating in the night. So one thing which is very common is these SSRIs. SSRIs can increase such dreams. So in the cases, this dream anxiety increases. So sometimes we are inevitably pushed to a situation where we are forced to continue a low dose of benzodiazepine with the antidepressant, maybe for a long time, hoping that tolerance doesn't happen. If tolerance happens, because that's the way benzodiazepines improve the sleep architecture and SSRI doesn't improve. So that's how the patients will always respond.
Just anecdotal, but then, sir, I had a patient 1 year back who came with a frantic complaint that whatever I see in my dream comes true. Now, it is not just cliched like what we see on TV or movie. Literally, she saw someone very close to her burning themselves by suicide. It happened. She saw the death, she foresaw the death of her father. It happened. So she told me, and it was not just 1 or 2. She gave me a list of about 7 or 8 such big significant life events that, okay, we have to look at it as something outside the textbook only. So she said, now I'm very scared to even sleep because the dream I see is anyhow happening. If it's good, I'll be happy. It's all negative. So then I gave her a benzodiazepine only because it
doesn't know what happened first.
yeah.
So people will, they will have such situations where they are not able to have a clear and sense of reality, dreams and life events.
Okay.
Yes. I mean, I also thought could it be an attenuated psychosis, could it be a prodrome? So these sort of things are there. When we tread upon those gray areas of extrasensory perception and all those things, it comes to our mind that gradually it's going to come as a full-blown psychiatric illness at some point at the time. Nothing else. So yeah, I think I've kindled a lot of interest among the audience. And we have also put a lot of inputs for the next speaker to pounce on. I think it's OSA. No? That has been looking at all those OSA slides. Oh no, dementia.
Thank you, ma'am, for a wonderful presentation. Ma'am, I just have like a query which I have been facing and I've been seeing through a lot of people being a psychiatric resident. So it's like with this advent of smartwatches and smartphones, I feel like we are facing this double-edged sword situation. Like on one hand, it actually looks at the quality of sleep. It tracks your sleep time, how healthy you are. And other end, I see that there are people who are apprehensive on the data that is being collected, and there'll be a decline in the sleep, and they'll actually come to the OPD saying, "Sir, I'm not sleeping well. I'm not. Look at this. It's coming lesser and lesser." So, ma'am, like in your experience, like how do we tackle this? Like, is it really good that they sleep with a smartwatch on or like a smartphone, or should we actually tell them no, it's not completely remove it out of the system?
See, in general, the way I wanted to make a point about digital addiction when I was talking about substance use and sleep. There is no systematic work that has happened, but then they say because of, because of the advent of internet and all related things, our sleep has got disturbed. So 20 years back, there was this publication which said that we are going to face doomsday because of digital distraction, death by digital distraction. This was 20 years back. They predicted it that we'll face doomsday because of something like this. I feel this has contributed a lot to anxiety prevalence, having increased over the years because of over information, misinformation, and things like that. So at least when someone with an anxiety problem comes to me and asks me, whether they ask or not, my prescription would be that please keep that away. Use it only to track your fitness, but nothing more than that. Your heart rate, your all the unnecessary parameters that could further, worsen their anxiety or keep giving them spikes of anxiety through the day. So I would say that for someone who's already predisposed, who's already anxious, definitely it would be better to stay away from it, keep it away in the night.
So a few other things are very interesting. Like generally, it's been in traditional teaching that patients of anxiety have more of an initiation problem, and the patients of depression have more of an early morning awakening problem. But the problem is, many patients of depression have comorbid anxiety, and it happens. But this also sometimes gives us an idea that which might be predominant in that person. But usually we see that this thing of sleep initiation difficulty is very prominent in patients with anxiety. So very nice. So I think after an exhaustive presentation, if no further doubts, we'll close the session.
Thank you, Dr. Deepa Gopinath, ma'am, for that remarkable session on sleep patterns and psychiatric disorders. Your exploration of how conditions like depression, anxiety, and schizophrenia disrupt sleep was both comprehensive and insightful. Your ability to connect the dots between sleep disturbances and psychiatric symptoms has given us a fresh perspective on the importance of addressing sleep issues in our psychiatric care. Your work is critical in improving the way we treat patients with occurring psychiatric and sleep disorders, and we deeply appreciate the clarity and relevance of your presentation. I now request Dr. Kailash Suresh Kumar sir to kindly felicitate Dr. Deepa Gopinath for her outstanding session. Thank you, Dr. Kailash Suresh Kumar, for excellent work as chairperson. We now request Dr. Gopinath to felicitate Dr. Kailash Suresh Kumar for his contributions. We now move to a session of obstructive sleep apnea, and we are honored to have Dr. Ganesham Verma, Professor and HOD of Respiratory Medicine, Sri Balaji Medical College and Hospital, as a chairperson for this session. He is also a fellow of Barkatullah University, Bhopal, and has done his post-graduation diploma in tuberculosis and chest diseases from Rani Durgavati Vishwavidyalaya. He has published 1 international journal and 14 national journals and a total of 9 publications in his prestigious journey. He is also a member of Indian Society of Critical Care Medicine and also presented many papers in national and international conferences. He is currently a postgraduate teacher in respiratory medicine, imparting clinical skills, bedside manners, patient care, intensive care, and motivating them to publish papers, a clinician and as a researcher. Now let's dive into an overview of obstructive sleep apnea. It is with great pride that I now invite Dr. Verma to introduce our esteemed speaker.
Morning all, and thank you, Dr. Priya Madam, to give the opportunity for the session. So I most welcome Dr. Joel sir. He is a consultant clinical interventional pulmonologist, sleep medicine in Villa Hospital Medical Center. He published more than 25 PubMed Index and international and national journals. He awarded a certificate of outstanding performance in chest. Challenge a competition in 2026 and 2028 organized by the American College of Chest Physicians. So I welcome Dr. Joel.
So first of all, I would like to thank the Department of Psychiatry, Balaji Medical College, and Dr. Priya ma'am and Srinivasan sir for actually inviting me here. So we all know why we have gathered here. That is the International World Sleep Day. So that is why we have gathered together across various specialties. And also I'm thankful to Gansham Verma sir, our department in charge, for actually chairing our session. So far we would have been discussing about various sleep aspects which is not related to pulmonology and other aspects. So one topic which I wanted to focus so much on is obstructive sleep apnea. You know, it is, as seen in the picture, it is just a tip of the iceberg. So quite a number of patients, especially in the last century, have been diagnosed with OSA and OSA related complications. So we all know the number 1 cause of death worldwide is due to cardiovascular events such as a heart attack or a stroke. And in majority, or at least I would say 2/3 of the patients had some amount of OSA when we looked retrospectively. That is the significance of OSA, and many times road traffic accidents also happen due to OSA. So having said all these things, this cannot be underestimated. So that is why I chose this topic, so that it can impart further evidence, especially for the practicing pulmonologists here, as well as from the other specialties. So with this, I'll go into my topic. So the agenda for today's discussion would be on the history of OSA and what is the normal sleep physiology. So what do we say by sleep disordered breathing, and the core concept of OSA, the pathophysiology involved, what are the clinical risk factors which you can generally see, as well as the features, and finally the treatment part. So this is the theme for this year's World Sleep Society Day. So we all, want you to make the sleep as a priority. So there should be no procrastination in sleep while using gadgets and other mobile devices. So aim for a good quality sleep of at least 6.5 to 7 hours when you go to bed. So just dwelling into history, so OSA, as I said, it came into existence or into awareness in the last 100 years. But what we know is the concept of obesity and sleep-related disorders was even described by William Shakespeare. So as you can see in one of his poems, he was mentioning. So this was the pictorial representation it had. So why I to put this slide is it has been there for decades. Only thing is the diagnostic trend has been recently improved here. The other aspect you can see the Charles Dickens novel, what we call as the obesity Pickwickian syndrome, where Joe is being portrayed as the fat boy. So this is also another example in the 18th century itself. So the existence of sleep apnea and sleep-related complications were being discussed in a fictional or a novel way with multiple authors. So I want to remember two important persons here. As you know, you can identify one is a physician from UK, so who is John Sain, and the other physician is William Stokes. So both put together what they gave as the chain-Stokes breathing, where you have an abnormal breathing pattern, especially at the time of during sleep in cardiovascular patients. So then moving forward, so this is William Osler who described the term Pickwickian syndrome in OHS. And Broadbent was the first journal which was published in Lancet about obstructive sleep apnea. So from the 16th, 17th and going on to the 19th century, OSA came into existence, and there were multiple theories at that time. So no one could explain what exactly is and what is the pathophysiology behind it and what are the clinical implications. So these are two important persons which I want to remember. At least one name here is William Dement. So what they established that sleep apnea is not related to just obesity. So sleep apnea can appear in a person, can occur in a person who is not even obese. So obesity is one of the most important risk factor, but not the factor. Multiple anatomical factors in the form of high arch palate or retronathia, as well as craniofacial abnormalities can also contribute to OSA. So this was published in 1977. And the first Sleep Society meeting was held again in 1977 in California. So CPAP is what we talk about quite often. Whenever we see a patient suspect OSA, we do a sleep study in that patient and then put him on a CPAP machine. The concept of CPAP was developed by Colin Sullivan, and you know before the origin of CPAP, many patients were undergoing a surgery called as UVPP. So this was done by a Japanese surgeon, Shigeru Fujita. So these are some of the important persons in sleep apnea and obstructive sleep disorders, which you can see. So just to make things interesting, so I just put in a couple of questions in between so that you can also pitch in. So maybe I'll take this with the pulmonologist per se. So what do you say, what does AASM stands for? Anyone can answer. It's open for the audience. Yeah, that's right. AASM stands for American Association of Sleep Medicine. Why this is important is they have been the pioneers. They publish the guidelines and other protocols, which we are being following it. And of course, in India, we have our own guidelines, what is called as the INOSA guidelines. Okay, the next question probably would be a little more harder. So who is considered the father of sleep medicine? So, yeah. So one clue I'll give, it was in one of my previous slides. Yeah, I can hear some answers, maybe mic in the audience. Yeah, I can hear the answer, but a little more loudly so that everyone will come to know. Yes, yes, absolutely right. So he is the father of sleep medicine. So I think we've got the history cleared well. Now let's move into the next topic. So this is the sleep physiology. So what is sleep? We all know sleep encompasses two phases. One is the non-rapid eye movement sleep. The other is the rapid eye movement sleep. So what you can see is that the REM sleep. Yeah. So what you can see is that in the rapid eye movement sleep that occurs in cycles like once in every 90 minutes, that is what you see. So good sleep should encompass at least 3 to 5 REM cycles. You can see in this hypnogram, there are multiple micro awakenings that are happening here, and you can see the REM here. So you have 1, 2, 3, 4 and probably 5. And when we see the duration of sleep, it is between 6.5 to 8 hours. So what are the physiological implications of sleep? So there are many to call for. Just when we look at the respiratory system, the ventilation drive is reduced. The ventilatory response is also reduced in terms of hypoxia and hypercapnia. So normally when we sleep, what happens is the oxygen saturation can fall by 3 to 5%, and especially if the patient is having OSA, I think it can get increased and attenuated. So moving on to sleep disorder breathing, there are multiple aspects with this. So am I audible without a mic? I think. Yeah. So as I was saying, the multiple aspects for OSA. So one would be a snoring and the other is an OSA. There's an overlap syndrome and central sleep apnea. So I think that's okay. So right. So we'll be talking about purely OSA in this snap matter. So what you can see in OSA is the most important aspect is you have to stabilize the upper airway. So when we talk about central sleep apnea, it is a ventilatory disorder that has to be happening here. So what is OSA? So in simple terms, there's a partial or a complete occlusion that is happening in the upper airway at the time of sleep, and because of which quite a lot of sleep fragmentation is happening in the patients. So if you want to remember, you have a disturbed sleep. The reason being is a choking that is happening in the level of the upper airway. So this you can see when we see a hypnogram, what you can see, there is a 90% reduction in amplitude. So when you do a polysomnography to characterize an apnea, what you can see is the duration is more than 10 seconds. Of course, all this will be discussed in the subsequent session, but just I want to give a hint. The effort will be there, but what the flow will be significantly reduced. So when we talk about hypoapnea, what you can see is there's a more than 30% drop and there's a desaturation. So these two components will make up the apnea hypoapnea index, by which we can quantify the severity of OSA into mild, moderate, and very severe. So when we look at the prevalence of OSA, so what several studies from the last decade and even before that have shown us, symptomatic OSA are very, very less. So you see very less number of patients coming to the outpatient department telling, I have a sleep disturbance, I am having choking episodes, I'm not able to have a good quality of sleep, there's an excess of daytime sleepiness. But when we screen many of the patients, what you can see is the prevalence is even higher. Roughly 1 in every 4 patients can have an OSA, and especially this is very high among males compared to females. Another important aspect which I want you to look is the age group. So this is the typical age group where OSA prevalence is significantly higher. After 65 years, there's a plateau in the prevalence of ASA that has been happening. So several studies confirm the same. So asymptomatic patients, 25%, symptomatic, it is around 2 to 4%. When you look at the overall prevalence in symptomatic as well as asymptomatic, it is roughly around 9 to 10%. So another aspect which I want to look at is only 16% have a mild sleep apnea, the remaining 10% have moderate to severe sleep apnea. So what is the pathophysiology or the pathogenesis? Why it is happening? So we said there's a deficiency in the upper airway anatomy as well as there's a decrease in the neuromuscular compensation. There are two important factors which are contributing to the development of obstructive sleep apnea. So because of this, the patient will go into an OSA. So you can see the upper airway here, you can see the nasal airway passage that is normal in a patient. However, when there are some abnormalities in the form of the lumen, the soft tissue, the shape or the length or even a nasal obstruction can cause it. Also craniofacial bone abnormalities like mandible is displaced, you have the hyoid bone which is inferior, you have an high arch palate towards it, these all can contribute to OSA. This is a classical example of a retrognathia. I can see this is the normal chin that is supposed to be here, it is slightly back. So gnathion is back and because of which the patient is having a narrowing. So what happens because of the depression here, the tongue muscles are further pushed back. So the upper airway is significantly narrowed here. So easily when the patient goes into sleep, he develops into an obstructive sleep apnea. The next is the hyoid bone. So when the hyoid bone is inferiorly displaced, then also the upper airway narrowing happens and leading to a development of AHI in many of the patients. What does this picture symbolize? Can anyone say? Again, coming back to the question. Yes, yes. So it's a high arch palate. So it's pretty straightforward. So this is again leading to a steepness in the upper airway causing airway compromise. So next is called as an overjet. So overjet means what you can see is the the teeth in the upper rim is slightly anterior and this in the lower set is pushed backwards, because of which the mandible is forward, maxilla, and this also leads to abnormalities in the upper airway, leading to the development of obstructive sleep apnea. When we look at the soft tissues, like some patients may be having a large tongue, what we call as macroglossia, the tonsil and adenoids may be enlarged. Even in some patients, severe jugular venous distension can also lead to an OSA here. So what you can see in a normal, how the upper airway is obstructed significantly in a patient who is having a huge amount of subcutaneous fat tissue that is there. And you can see this is, can you identify what this is? So it's a tongue with indentations that has happened due to macroglossia so many a times. And this again lateral narrowing that is happening due to pharyngitis. And you can see this is an enlarged uvula in this patient that is there. So why I'm stressing all this is, whenever we say OSA, it is just obesity. So it is much more beyond obesity. So we need to look on all these factors, and it is not a single specialty subject also. So you have to incorporate multiple specialists to actually have a look. So, and several studies have also shown that even an excessive distension of the jugular vein, such in case of CKD and other chronic disorders, have also led to a development of OSA. So even when we see a DNS, a deviated nasal septum, or a turbinate hypertrophy, because of the negative pressure that is developed so much, the pharynx becomes more collapsible. This also can precipitate OSA. So these are the risk factors which I just summarized. The other factors like the pattern of fat distribution, and then you see the gender, the menopause, smoking, alcohol, body positions also play an important role. So coming back to obesity, so which we are talking here, what you can see is there's a 4-fold increase in OSA for every standard deviation when the BMI is more than 30. So of course, 25 to 30 is in the overweight category. We are going talking more about that. So what does it do actually? So what you can see, the anatomy is altered, the airway collapsibility is increased, the respiratory drive is depressed, and also the exacerbation of OSA events are also precipitated. And the other thing, more than obesity, the pattern of fat distribution is very, very important. So that is where the difference between male and female comes into play. What you can see, a centripetal pattern of obesity with preferential deposition in the neck that is happening. And especially in many of the females, what we see is that it is around the hip and the thigh area. Then males, you have this. So this is an important aspect. But even in females who have been on steroids for long term and they have Cushing syndrome, they can develop this type of pattern. So that is why I always see a neck circumference in most of our patients when they compare to our OP practices. So more than 40 centimeter, it is an alarm the patient may be having OSA, and higher the neck circumference, there's a greater the chance of severity of OSA. So again, one more question, since I wanted to be somewhat interactive. So what do you call a person with a BMI of more than 40 and 50? So I am sure everyone would agree more than 30 is obesity, right? So yeah. Yeah, so more than 40 is morbid obesity. So what about more than 50? You can just give it a try, Yeah, some answers I'm getting. So this we call as super obesity. So this is what I want to understand. So at least 2-3 slides I wanted to register in your mind before leaving here. Right. And I said when we talk about the prevalence and gender, as I said, the fat deposition is one aspect. The other is the length of the pharynx and the upper airway resistance. The hormonal factors also play an important role. We all know progesterone is a respiratory stimulant. So it stabilizes the upper airway. On the other side, what you can see, testosterone, what does it do? It is contributes to fat deposition in the neck, therefore having a higher prevalence of OSA. But having said all this, is what about the postmenopausal women? So the high estrogen and progesterone is only at the time of the normal fertile period. So several studies have shown that there's a 4-fold increase in OSA in postmenopausal women. And when these patients were given a hormone replacement therapy, what you can understand is that the apnea hypopnea index has significantly reduced. So then we move on to ethnicity. So there are significant contrasting data here. What to conclude is Asians and Africans have slightly higher prevalence of OSA compared to Caucasians. So this is definitely not in our hands, which we can understand. So age is probably controversial, not well understood. So what I said is 30 to 60 years is what you have to look for the screening of OSA, and it plateaus above 65 years of age. An important factor in elderly people is the decrease in the muscle tone that is happening in this patient. So what about smoking and alcohol? Again, smoking will cause an increased airway inflammation leading to mucosal edema that may contribute an OSA. And same time, when we look about alcohol intake, there's a reduction in the tongue muscle activity like the genioglossus and the hypoglossus, and the reduction in the arousal response, as well as the sleep gets fragmented. So all these are potential risk factors which we have to counsel our patients when they come for an OSA evaluation. Some more specific diseases which I'll just run through. We all know some of the neuromuscular and chest wall disorders can also contribute to the development of OSA. So stroke, why I'm bringing up stroke here is, sorry. Sorry if I'm not been audible just now. So why I'm bringing stroke here is OSA can lead to the development of stroke as well as cardiovascular side effects. But those patients having stroke can develop a second stroke due to OSA. So because as due to stroke, the muscular activity and the resistance is significantly reduced, the upper airway is again getting collapsed, then the OSA develops in that patient. Then there's a spike in the blood pressure, then you have a second stroke, which can be an hemorrhagic stroke also. So even in stroke patients, I advise you to look for an OSA evaluation. Snoring. So snoring is the first symptom or which we see in many of our patients. It is just like the tip of the iceberg. But isolated snoring may also be present due to a deviated nasal septum or turbinate hypertrophy. The patient may not have sleep apnea. But if the patient is snoring excessively and there are pauses in between and there's a choking episodes, I advise that patient to undergo a screening for OSA. Now, body position, what we call as POSA. So some patients lying supine, so because of obesity and gravity, they have a chance of sleep apnea. They generally fall into the mild or the moderate category. So in these patients, what we advise is you try to change the position either in the left or right lateral position. The OSA significantly reduces in these patients. So this can be tried as positional therapy in some of our patients. Again, as I said, gravity, you can see here, normal when you have a pillow and sleep, see how it is there, and when you don't have, see how the resistance is collapsing here, and you can identify. Now, quantifying the severity, as I said, the apnea, hypoapnea index, normally you have up to 0 to 5 in an hour. So anything more than that, so 5 to 15, we characterize mild, 15 to 29 is moderate, 30 and above is severe. So severe, if the patient is having OSA, there's a higher chances of developing cardiovascular and neuromuscular side effects. So what are the consequences? As I said, one is the apnea that is happening. So there's a loss of oxygen that is going in, so negative intrathoracic pressure. Basically, it will behave like a person is literally being choked with a hand. So what we'll do are all our hormonal responses, the adrenaline, noradrenaline, the sympathetic surge increases so much, there's a spike in blood pressure. So sometimes when it reaches more than 200 or something, so it may dislodge the plaques which are already present in the coronary arteries. That is why you see some of the heart attacks and stroke that is happening very frequently in the early morning period. So this is the most important reason. And any patient who is having a severe hypertension, it is not controlled by say 1 medication, 2 medication or 3. So you all probably have to look for for sleep apnea as well as pheochromocytoma. Then we see about the consequences. You can see a fragmented sleep. So normally sleep is meant to be so peaceful and uniform others. But when we see an OSA patient, you can see the patient never goes into a deep sleep. So because of this, even though the patient may be on the bed for 8 hours or 10 hours, but when he wakes up, he feels fatigued. So there is an early morning headache. So that is carried away into the daytime by excessive daytime sleepiness over a period of time that can contribute to anxiety, depression, mood swings, and a loss of productivity and other outcomes. So these are some of the important side effects which I want you to understand that is there. So main is the cardiovascular as well as the CNS side effects. Other complications like metabolic syndrome that can happen, drug-resistant hypertension, which I already discussed. The patients may even have atrial fibrillation as well as heart failure. Yeah. So this is again say, so and one more thing is increased road traffic accidents. So I want to stress this very much is that because of this in US, UK and other aspects for this, you need to get a license from a sleep physician whether the person is fit enough to drive. So unfortunately, we don't have that in our country as of now. So how do you screen? So one, we have a physical examination where you can ask the patients the relevant questions. Then you can ask questionnaire-based devices and also the devices and oximetry monitoring. So I have talked about so much risk factors now. Again, it's time for some questions. So what are the risk factors you identify in this picture? So I can hear one: obesity, yes. Substance abuse, yes. Smoking and alcohol. So you're all alert and awake, so I'm happy. So the risk factors, as you correctly pointed out all this, what you missed out was the male gender, because that is the only thing there, because so there's a 2:1 prevalence of OSA among males compared to females. So one more question. So what are the risk factors in this picture? Yeah, I think you're absolutely right. It is old age and postmenopausal. That is the reason. Right. So I'm going on to the signs and symptoms. As I said, the patient may have a resistant hypertension. There may be nocturnal arrhythmias, heart disease, and diabetes may be present in these patients. When we see about the symptoms, you see snoring, you can see headaches, there may be mood swings, which I already discussed again. So how do you screen for this? You can have a physical examination of the upper airway, measure the neck circumference, ask for history of any accidents or decreased memory, or there's a decrease in work performance or excessive tiredness that has been happening. So there are certain objective ways of measuring this also. One, we have the Epworth Sleepiness Scale that is available. The second thing is the Berlin Questionnaire. So these are readily available in the internet, which you can easily go to and see, and we can have an OP practice also. One simple aspect is the stop band questionnaire. I want everyone to keep this in mind. This is validated over a long period of time, and this has shown to be an excellent screening tool. So yes is for snoring, T is for observed tiredness, tiredness or fatigue, O is for observed apnea, and the P is for high blood pressure. So can anyone say what would be the part of B, A, and G? BMI, yes. Age more than? Okay. Next circumference? 40 and male gender. So these are the things. So 40, 50, and 35. So this one I want to remember. So if you can have this in with you in your mind, you can easily screen the patients for OSA. So other ways you can also screen with the pulse oximetry. So you can see actually it's the pulse oximeter in the night. What you can see is there's a drop in saturation whenever there's an apnea or hyperapnea going on, but you need to have a continuous monitoring. So this will not be able to detect like it is a central sleep apnea or a mixed apnea or an obstructive sleep apnea. So that is the side effect here. So that is where you need a polysomnography. So there are many types of polysomnography, level 1, 2, 3, 4. Level 1 is the complete type. We have the ECG, EEG, you have the EMG, you have all the electrodes, so around 9 parameters. So which may not be required for a diagnosis of a simple OSA. If the patient is having a hypoventilation syndrome or a neuromuscular disorder, or there's something abnormal in his cognitive features, then probably you can plan for a type 1 sleep study. Otherwise, type 2, 3, 4 are available. What we commonly advocate for OSA is the type 3 out-of-center sleep study, where the sleep study can be done at the home itself with just 4 channels. This is an example of a type 1. You can see so many things which is installed in the patient. This has to be done in a dedicated sleep lab, and a sleep technician has to be there all the time. So these are something which I just spoke about. So this is how the graph will be look when we talk about the type 1 sleep apnea. Type 2 devices the same, but you don't have need to have anyone monitoring it. And type 3 is the portable one, which can be used at home. And type 4 is the minimal one, where you just look at the nasal flow, the oxygen saturation, as well as the respiratory effort. So again, as I said, the guidelines of our country recommend to do a type 3 sleep study in a pure OSA. When we can suspect other things, go for a type 1 or a type 2. Moving on to the treatment. So there are multiple treatment options. So the core here is when we see the sleep apnea is due to obesity. So say, for example, the treatment or the gold standard treatment is to cut down on the obesity. So, but it is not in a one day or an overnight process. It may take several months or years for that to achieve. So before that, the patient has to be prevented from the complications. So that is where your medical treatment in the form of PAP therapy comes into play. So, but always counsel the patient to cut down on weight, change his lifestyle, and also smoking, alcohol, and other sedatives that has been he's been taking for a period of time. So you can then start him on CPAP or a BiPAP or auto CPAP depending upon the comfort and the reports of the sleep study. Some patients may have some upper airway abnormalities where the dental appliances, the maximum mandibular retraction devices may be helpful. And in very selective patients, simple lifestyle modification or positional therapy may also be helpful. So sleep hygiene is what I want to you to understand, which we want to stress in all patients, not just in OSA, but anyone with insomnia and any other sleep disorders. So what are the tips that you have to, the sleep has to be a dedicated place. You should not be doing a routine activities there. The blue light has to be completely reduced. You have to create a suitable environment. The AC temperature should be adequate. The patient should go to bed only he is going to sleep in the next 30 minutes. So it's not lying in the bed for several hours and then saying that you are not getting a sleep. So these are some of the advices which you can give to the patient. So as I said, there are multiple devices which are available, which again is a different topic altogether. So I won't go in detail into all these. So a simple way to understand, if the patient is having pure OSA, think of a CPAP. If the patient is not comfortable on a CPAP or you have not done a level 1 sleep study, then you can give him an auto CPAP or APAP. The patient is having central sleep apnea or nocturnal hypoventilation, probably you have to think about a BiPAP with an backup respiratory rate, what you as the ST mode. So this is the CPAP here, what you can see, a constant pressure that is going on here. So the problem with this is that sometimes the patient may need a pressure of say 7, sometimes he may need a pressure of 10. So if you give him a low pressure, it may not be that effective. If the pressure is constantly high, the patient's sleep pattern may get disturbed. So that is where the auto CPAP comes into play, where it senses the changes in the upper airway pressure and gives accordingly so that it is more beneficial to our patients. On the flip side, what happens is many a times patients just do a sleep study, get a auto CPAP, do not check themselves or evaluate further to have any other complications associated with this. Yeah. So bi-level therapy or BiPAP. So on whom do we need BiPAP? So BiPAP is basically two pressures. One is the inspiratory pressure, what we call as the IPAP, and the other is the expiratory pressure, what we call as the EPAP. So these are patients who are having ventilation problems and the carbon dioxide level is too high, the work of breathing is difficult, and the patient is having some neuromuscular issues. That is where BiPAP is very helpful in these patients. And another important aspect is if the CPAP pressure is more than 15. So you need to give very, very high pressures. In that scenario also, BiPAP will play an important role in improving it. So as I said, so when do you recommend CPAP? So there are two simple indications which I want you to remember. You do a sleep study. If the AHI is moderate or severe, even without symptoms, you can directly advise for a CPAP therapy in this patient. If the patient falls into the mild category, that is the AHI between 5 to 15, but the patient is very symptomatic or he's having comorbid conditions like uncontrolled hypertension, diabetes, or heart disease, there also you can suggest an auto PAP therapy in these patients. So you always, when we start on PAP therapy, you have to think about the compliance, make the patient comfortable, try to make him understand the benefits of the mission, as well as reassess and reevaluate with the sleep data every 2 weeks. So this is what I want you to look into. One is the mask, that the patient's having several types of masks, like a nasal mask or oronasal mask or a full face mask. Then education about the importance of having this and what is the humidification that is required. Because many a times when the air is blowing dry, what happens is the patient will find some difficulty due to nasal dryness and other things. So most of the CPAPs come with an inbuilt humidifier. So make sure that humidification is already there in these patients. So how to establish a sleep clinic? This has to be a multimodality approach. Of course, since me being a pulmonologist, I put my name first. Then you have an ENT surgeon for the upper airway abnormalities. You may need to have the help of a bariatric surgeon if he's having vision morbid obesity, where they can benefit from all these things. Then an endocrinologist to control the metabolic abnormalities. You need a cardiologist to look for the sleep complications. As I said, the dietitian, even the oromaxillofacial surgeon or the dentist may be required, as well as a neurologist to look into the neurological aspects of sleep. And finally, when we need the psychiatrist. So it's not the last, but they are also more important. That is what I mean to say in this slide. So when we have all these integrated specialties together, I think we can easily identify, because not all sleep disturbances are OSA. Some may be having a central sleep apnea, some may be having an insomnia, some may be having anxiety disorders. We just need to have a multimodality here. So to summarize, so last 25 minutes on, the burden of OSA is very overwhelming. It is not restricted to obesity alone. Snoring is only the tip of the iceberg. So many patients can still have OSA without any snoring. Pathogenesis, which I want you to remember, is upper airway collapse, which is very much exaggerated, and the lack of neuromuscular compensation. Three important complications, as I said: heart attack, stroke, and road traffic accidents. Use your stop bank questionnaire in clinical practices. And upper airway assessment has to be done when the sleep study is normal, but the patient is still symptomatic. So I'll conclude this by saying a healthy sleep and a healthy life, and on this World Sleep Day. Thank you.
Thank you, Dr. Joy. A wonderful presentation to covering all aspects of OSA. Now, session is open for question. Anybody have any question?
My good friend,
When I want to do the break, I have some problem with snoring. I don't know whether it's an impact on OSA, but people complain about that usually. They have not doing the yoga practice daily. After 4 or 5 days, they have developed some snoring symptoms. They're having an impact on that.
So, like as you said, for OSA, we don't know whether it may help or not. But one important benefit with all breathing exercise yoga is that it improves your airway muscle tone and resistance. So if the airway upper muscles are strong enough, so they can ward off the mild sleep apneas as well as the other aspects. So breathing exercise, if they are okay to do it, definitely they can proceed with doing it. But does it cover the entire aspect of sleep apnea, or does it nullify the use of CPAP? It may not be.
Thank you, Dr. Joel. Very relevant topic, even for a psychiatrist, because in many instances, people keep reporting with sleep disturbance. And unfortunately, I had a client like where he has been given benzodiazepines, but it was not helping him. He was sleeping through the day, and ultimately, when I just evaluated, he was having reporting of symptoms of sleep apnea. So when he was underwent polysomnography and then he was put under CPAP, his benzodiazepines could have been reduced significantly. So this is one thing, like even a psychiatrist should be aware, like this is one of the entity, because we deal with sleep but other associated concerns. And it is a very wonderful topic. I just want to know, like as a psychiatrist, like having introduced these kind of CPAP or whatever, how frequently should we review it? Because if our client is on this thing, like how should we advise, like for when to stop, or what is the review that they have to do with the pulmonologist?
So yeah, so that's a very important question, especially so we can all put them on treatment. So when to discontinue, the patient will obviously ask, so you put them on me on CPAP, so what next? So first part should be focusing on the compliance. So many times the patient may not be compliant. So I've seen some patients using the CPAP at daytime for the sake of using it, and when they go to bed, they remove the CPAP device. So you have to educate them the importance of CPAP is, especially at the time of sleep. So minimum compliance, what we say is 4 hours. So that is important. So call them at the first visit probably in 10 to 14 days. Every CPAP has an inbuilt chip. So it collects all the data. It will tell about the AHI index. You see how things are going. and it will also give about the compliance data. So that is the thing. Second thing, when we ask, so when do I discontinue? So I say in many of patients, like your BMI and other things are so and so. So if you can cut down on this much of weight or BMI, probably in a healthy way in 6 months or 3 months, that is depending on how much you can do, then we can always repeat a sleep study and assess. And if the sleep study has come within into the normal range, probably we'll think of discontinuing CPAP therapy. So roughly what we've seen is in the majority of the patients, it has been around 1 year. So that is why we have been able to discontinue. Some, of course, some milder patients who are more motivated, maybe in 3 to 6 months also, they have been benefited. But this is those patients only with an obesity component, which is there. Some patients with anatomical abnormalities, so the other specialists have to pitch in, and as per the advice, we'll have to decide.
Thank you.
Thank you.
Mhm.
Thank you, Dr. Boer.
Yes, sir.
So we conclude the session.
Dr. Venkatesh, Shadrach, for your exceptional presentation on OSA, your thorough explanation of the pathophysiology of OSA and its impact on health, particularly its relationship with psychiatric conditions, was both enlightening and timely. The treatment options you have enlightened, such as CPAP, are critical for improving patients' outcomes, and we are grateful for the practical insights that you have shared today. Your session has given us much to think about in terms of integrating the treatment of OSA into our overall care. I now request Dr. Verma to facilitate Dr. Venkatesh Shadrach for his valuable contribution to this session. For our final session, Dr. Verma will again chair the session on polysomnography, a vital diagnostic tool in sleep medicine. Dr. Verma, please introduce our esteemed speaker.
Good afternoon, Dr. Boobala. We welcome Dr. Boobala Aravinthan. He's an MD, DMV. He's a consultant pulmonologist, sleep specialist in Kuwait Sleep Medical Center, that is in MOH Kuwait. Dr. Boobala Aravinthan is a highly skilled pulmonologist, sleep medicine specialist with extensive expertise in diagnosis and management of respiratory disease, sleep-related breathing disorder, complex pulmonary condition. He is currently considered the Sleep Center, a pioneering institution dedicated to advancing the diagnosis and treatment of sleep disorder. With a strong background in pulmonology, sleep medicine, Dr. Boobala is committed to improving patient quality of life by integrating the evidence-based approaches in respiratory care. And sleep health is contribution to the Kuwait Ministry of Health play a significant role in shaping a modern sleep medicine service in this region. So we welcome Dr. Aravinthan.
Yeah, click the slideshow.
Am I audible?
Yes, continue.
Hi, good afternoon all. I'm very happy to be here as a part of Sleep 360 on the occasion of World Sleep Day. I would like to thank Dr. Priya Shivashankar, Professor and Head of the Department of Psychiatry, and other organizers for the opportunity to speak with you. So here I will start with the polysomnography. Let's start with a little bit history of how sleep medicine evolved. In 1929, Hans Berger, he developed EEG for brain activity. In 1937, sleep stages categorized by Loomis, but he categorized only non-REM sleep. Mainly, he divided into 5 types, 5 stages as A, B, C, D, E. But the turning point is by Demant, he discovered REM sleep in 1952 with the help of electroacoustigram. He is the father of sleep medicine. From here onwards, the sleep medicine evolution started robustly. The first sleep disorders center was established as a narcolepsy clinic at Stanford University in 1964. 1965, sleep apnea was discovered by Gustard and his colleagues in France, at the same time in Germany also. The staging criteria were standardized in 1968 by Richthofen and Kales. And in 1974, Dr. Fallon named this test as polysomnography. Actually, this is the early time polysomnography machine it's called analog polysomnography. The previous one, this one is the modern day digitalized polysomnography. So polysomnography, it's a multi-parametric sleep study which is used as a diagnostic tool in sleep medicine. It is the gold standard test for obstructive sleep apnea. Before going into the polysomnographic study, I want to describe types of sleep studies. There are 4 levels of sleep study: level 1, level 2, level 3, level 4. The level 1 sleep study or polysomnography. This is the center-based full attended study. Maximum measures has been taken in this study, like EEG, OG, EMG, EEG, ECG, airflow, respiratory effort, and oxygen saturation. The difference between the level 1 and level 2 is the level 2 is an unattended study and out of center study, but it's not regularly used, not routinely used. On the level 3 study, it's a portable monitor. It's a home sleep test. Here, they are using respiratory effort and airflow channels, heart rate, and oxygen saturation. The limitation of this home sleep test, we can't able to find out the sleep stages and position. So, which underestimate the AHI, already discussed apnea hypopnea index. And at the same time, we can't able to find out in which sleep, like REM sleep or non-REM sleep, have high AHI, and in which position high AHI is there, whether supine position or lateral position. These are the limitations in the home sleep apnea test. And the level 4 we used as a screening test, mainly O2 saturation or respiratory effort. Sometimes they will use both for screening. So indication of polysomnography: diagnosis of sleep-related breathing disorders like OSA, central sleep apnea, or obesity hypoventilation syndrome. At the same time, titration also done by the polysomnographic study. Here, there are 2 types of titration. One is manual titration, and another one is automatic titration. Manual titration done by this polysomnography. Auto titration means there is a other device, auto CPAP. You can do the titration at home itself. After some time, in the later part, I will discuss about the titration. The third one is assessment of treatment results, which means we can find out the efficacy of oral appliances or other sleep surgery measurements, how it worked. And the third one is, fourth one is multiple sleep latency test for diagnosis of narcolepsy, maintenance of wakefulness test for the assessment of efficacy of treatment, part of narcolepsy, REM sleep behavioral disorders, even movement disorders like periodic limb movement disorders, we can able to find out through polysomnography. Yes, today mainly I'm concentrating on obstructive sleep apnea in PhD. So here there is a data in the US. It shows prevalence of OSA around to 12% of the population in the US. Among the 12%, 80% of the population undiagnosed. Only 20% is diagnosed. Previous speaker, Dr. Ben, as he discussed, if the patient undiagnosed, the patient will develop a lot of comorbidities like diabetic hypertension and cardiovascular disorders like stroke, MI. So the early diagnosis of the obstructive sleep apnea is good to avoid this kind of comorbidities. So before starting polysomnography, we need to ask good sleep history. Whether patient have a good duration of sleep associated with naps, any naps, sleeping habits. We need to ask about the time in and time out if there is any interruption. Quality of sleep, whether it's refreshed or not. Is there any snoring? Abnormal behavior during sleep, any abnormal movements? Is there any apneic events? Daytime functioning, which means whether patient active or tired or fatigued, he can able to concentrate on the work or not. And personal habits, like he has any addictions, medical history, he has any other comorbidities or any other psychiatric medication he's taking in a drug history, we can ask. And occupational history, whether patient on nighttime duties, any night duties like that. So after good history, we have to ask, we have to do good physical examination. We need to check a body mass index, oral examination to find out any high arched palate or any tonsil or large tongue, and nasal cavity we need to examine for any nasal deviation. And neck circumference we need to measure, mandibular deformities and any maxillary deformities we need to assess. After the good clinical history and physical examination, we need to screen the patient for OSA. There are 4 kind of questionnaires: stop bank, stop Berlin, and 4 variable. Among these, the stop bank is high sensitive to find out the risk assessment of the OSA. Stop bank questionnaires already discussed by Dr. Ben. These 8 parameters we have to assess. Each parameter, if there is yes, we have to put 1 point. So if there is 0 to 2, then we have to consider mild. If 3 to 4, we have to consider moderate. If more than 5 or more than 5, we have to consider severe risk. If the patient moderate or severe risk, we can go for home sleep test. If the patient without any comorbidities, which means moderate and severe risk patients without comorbidities, we can go for home sleep test. The patient moderate and severe risk, but at the same time he has any comorbidities, we have to do polysomnography test. And the mild risk patients, we have to go polysomnography. And airport sleepiness scale, it have 8 parameters. It's mainly used for assessment of excessive daytime sleepiness. If the patient have more than 10, then we have to consider excessive daytime sleepiness. Then we can do polysomnography. So I will go into the component of polysomnography. It is a continuous monitoring and simultaneous recording of the physiological activity during sleep. It monitors sleep parameters, respiratory parameters, EKG, leg movements. It's again general parameters. Yeah, this is the kid who is ready for polysomnography after hook up all the signals. First, we will see about EEG signals. In routine polysomnography, we used 3 EEG signals, one on frontal, another one is central, and the last one on occipital region. International 10-20 system used for placement of the signals. Recommended derivation. Actually, and one more thing I want to say, there are 2 reference leads we need to keep for the in the master process. Recommended derivations are F4M1, C4M1, and O2M1. Backup electrode should be placed at F3M2, C3M2, and O1M2. Here you can able to see clearly the electrodes kept on F4, C4, and O2 on the right side with the M2 reference. In the left side, you can see the F3, C3, O1, and M1 in the left side. Usually, the odd numbers are in the left side and even numbers on the right side. You can remember easily. So here, I want to show some waveforms. The alpha activity. Alpha activity is a waveform you can able to see clearly in the O2 leads. which have 18 to 30 hertz frequency and variable amplitude and a sinusoidal pattern of shape. It usually seen in the wakefulness stage wakefulness. Here you can able to see the sleep spindle in the central lead. This one have 11 to 16 hertz of frequency and amplitude is variable. Shape will be sinusoidal, but the duration should be more than 0.5 seconds. This spindle waveforms will be seen in the sleep stage N2. Yeah, the another waveform K complex. It's usually seen in the frontal leads. There is a clear negative deflection. After that, there is a positive deflection. Usually, the upward deflection called negative deflection and the downward deflection called positive deflection. The morphology of K complex amplitude variable, frequency will be less than 2 hertz, and the duration will be more than 0.5 seconds. This K complex also seen in the stage N2. And here you can see the slow wave or deep wave. The important point here is rest of the all waves different amplitude, but here the slow wave must be 75 millivolt, more than 75 millivolt amplitude should be there. Usually seen in the frontal lobe. If the slow wave more than 6 seconds available in the epoch polysomnographic recording in the 30 seconds, then you can consider as a N3 sleep, stage N3. And one more wave, actually this wave you can able to see all the EEG recordings after once the sleep started. This wave called LAMF. LAMF means low amplitude mixed frequency. These are LAMF. Between the slow wave, you can see LAMF. Between the spindle, you can see LAMF. So whenever sleep started, you can see the LAMF. In the background of LAMF, all the other waves will come and go, but the LAMF always will be the constant. The LAMF frequency will be 3 to 7 hertz and variable amplitude. So these are the description regarding ECG waveforms I already told. The next one is electroocculogram, recording the movement of cardioretinal potential difference, not the movement of the eye muscle. Here there are two types of lead position. One is recommended and acceptable. In the recommended, in the left side, 1 centimeter lateral and 1 centimeter lower to the left outer canthus, lead E1 can place, and 1 centimeter outer and 1 centimeter upper, lead E2, we can place the lead E2 here. But in acceptable, both the leads should be outer and lower. But most of the time we will use recommended leads. In EOG waveforms, we can able to see 4 kind of waves. One is slow eye movement. You can able to see clearly there is a slow roll over the movement here. The deflection time will take more than 0.5 seconds. But in the rapid eye movement, there will be sharp waves. The deflection will be less than 0.5 seconds. In the reading eye movement, there will be initially slow movement. Once it reaches the peak, then there will be sharp movement. The blink, it's 0.5 to 2 hertz of movements. Actually, in the recommended state, these waveforms will be out of phase. You can see opposite direction it used to move. But in the artifact or acceptable position of lead, you can see the waves will face each other, means moving each other together. Chin EMG, here you can able to see the 3 electrodes One is placed just 1 centimeter above to the inferior angle of the mandible along the line of the midline, and other two leads placed 2 centimeter away and 2 centimeter lower to the inferior angle of the mandible. Actually, the role of chin EMG here is to differentiate REM sleep from non-REM sleep. If the electrical activity is more, then you can able to say this is non-REM sleep. If there is no electrical activity or minimal electrical activity, then we can say it's a REM sleep. This is the importance of chin EMG. ECG lead, actually, there is only one ECG lead. We used lead 2 and lead 2. There is a leg electromyogram which is placed on the anterior tibialis muscle, mainly for diagnosis of limb movement disorder, like periodic limb movement disorders. Then we will go to the respiratory parameters. Airflow signals, respiratory effort signals, snoring, oxygen saturation, CO2 levels coming under the respiratory parameters. Here for airflow, we have two signals. One is oronasal thermistor, this one. With the help of this oronasal thermistor, we can able to find out the apneic event. Here, the next one, nasal transducer. With the help of this one, we can able to find out the hypopneic event. Then here you can see the belt, RIP belt. This is respiratory inductance plethysmography belt. Usually we used to keep two belts, one at the level of umbilicus and another one at the level of nipple to find out the respiratory movements. And here we are keeping the microphone for find out the snoring. For oxygen saturation, we used a pulse oximeter, and for the CO2 level, we used ABG or transcutaneous CO2 monitoring or end-tidal CO2. Usually, these CO2 levels we measured only those patients we suspected chronic alveolar hyperventilation patients, like neuromuscular disorder or obesity hyperventilation syndrome. So, in the polysomnography report, you can able to see clearly there is a oronasal transducer, nasal transducer, thoracic abdomen belt movements, microphone snorings, and saturation, and even body position you can able to see here. Other sensors, body position and a synchronized PSG video. PSG video also must to assess the, if we have a doubt regarding REM movements, REM sleep behavior disorder and limb movement disorder, periodic limb movement disorder, we can use the PSG video. So once patient hooked up, we need to do machine and physiology calibration, and we need to check the any artifacts. Then we will turn on the light, turn off the light. Then we will ask the patient to sleep. Usually 6 hours we will take, minimum 6 hours we will take for the recording. After 6 hours, we ask them to light on. Then we will do a machine and physiology calibration once again. Then we can stop the study. Then all sensors can be removed. The important thing here is we need to measure the total recording time, sleep onset, REM sleep onset, and VASO. VASO means wakefulness after sleep onset. With the help of VASO and sleep onset, we can able to find out the total sleep time from the total recording time. So sleep study analysis and scoring. Here we need to go step by step. First we need to go sleep staging, then we need to do arousal scoring, then respiratory event scoring, then movement event scoring, then cardiac event scoring. If we do respiratory event scoring without any sleep staging, we will do a lot of mistakes, because we can't able to consider if any apnea, hypopnea occurred in the wakefulness. So always we need to do first sleep staging, arousal scoring, then respiratory event scoring. epoch. Epoch is the basic unit. Actually, epoch refers to each 30-second segment of polysomnography recording. Actually, this is the polysomnographic recording. In this polysomnographic recording, here you can able to see, I think 30 seconds, 20, 30 seconds. This 30 second is called one epoch. Each epoch has been staged by sleep. We need to do sleep staging and arousal and cardiac score. But respiratory and limb movement, we need 2-minute window, which means it has 4 epochs, 4 30-second epochs for the respiratory and leg movements. So now we will go to the staging. There are 2 rules for the staging. Until 2007, we used Retzefan and Kale's rules. According to the rules, he only divided wake, non-REM, REM. In non-REM, he divided into stage 1, stage 2, stage 3, stage 4. But after 2007, American Association of Sleep Medicine manual made a staging rule. Actually, they made a staging rule for pediatric age group, infant age group, and adult age group. This one is for adult. In adult, stage wake and stage N1, stage N2, N3. There is no stage N4 in non-REM, and there is a stage R. And also, they made a rule for respiratory movements, respiratory scoring, arousal scoring, and limb movement scoring. First, we will start with wakefulness. Wakefulness usually showed in EEG as an alpha wave should be present for more than 15 seconds of epoch. And EOG have sometimes REM movement or eye blinking or reading eye movements. EMG have high frequency activity. Here, actually, you could not able to find out any alpha waves, but excessive EEG activity and beta activity, because here the patient awake and opened eyes is moving here and there. That's why you can't able to find out any alpha activity. But here, once patient closed his eyes, you can able to find out the clear alpha activity here, which is more than 15 seconds, and sinusoidal pattern and morphology also have more than 8 to 13 hertz. And stage N1, N1, alpha waves should be replaced by LAMF waves for more than 15 seconds without any sleep spindles and K complex, which is not associated with arousal. And EOG also have sometimes slow eye movement. EMG have less activity. You can see here clear LAMF activity. It's 3 to 7 hertz. I already told you the most of the background activity. Once you saw the LAMF activity, then you can consider sleep has been started. But in this epoch, there is some arousal. We will discuss about arousal later. This is arousal. And stage N2. Stage N2 in EEG, if sleep spindle or K complex not associated with arousal is present in the first half of the epoch, then score it that epoch as N2. Here you can able to see the sleep spindle and K complex also in the lead frontal lead. So we can consider this epoch as N2. The N2 sleep stage has been started. If this K complex or sleep spindle in the second half of the epoch, then we should not consider this epoch as N2. Then the next epoch we need to consider as N2. Then sleep stage started as N2. Here, no eye movements and EMG activities compared with the N1 and wakefulness, it will be more decreased activity. Stage N3, EEG shows slow waves for 6 seconds or more than 6 seconds of the epoch. EOG shows no eye movements and EMG activity will be very low. So it's called deep sleep. Here you can able to see the slow wave movements, which is amplitude more than 75 millivolt and more than 6 seconds. So this one is considered stage N3. And stage R. Usually stage R have a clear LAMF activity, only LAMF activity, low amplitude and mixed frequency activity. And EOG shows clear here rapid eye movement and clear slow EMG, which means there is no activity of EMG or very less activity of EMG here. So in this stage, we can consider stage R. But there is a different rule for the end of stage and starting of another stage. Here, hypnogram. Hypnogram means it's a graphical study of whole sleep. Whole sleep. In normal adult have 7 to 9 hours of normal sleep. Among the 7 to 9 hours, there will be 4 to 6 sleep cycles. A sleep cycle means from the wake to the end of the REM sleep. Then the next sleep cycle will start from the end of the REM sleep and the initiation of another new REM sleep. So each sleep stage have 80 to 120 minutes normally. In initial stage of the sleep, you can see a lot of N3. In the late stage, you can able to see lot of R, stage R. In N1, stage N1, usually 3 to 8% of the sleep. N2 will be 40 to 45% of the sleep. N3 will be 15 to 20% of the sleep, and stage R will be 20 to 25% of the sleep. Here the sleep scoring data we already discussed. The important point here is we need to measure the total sleep time, total recording time, sleep latency. From there, we can able to find out the total sleep. From the total recording time, we can able to find out the total sleep time with the help of sleep latency and VASO. Arousal. Here EEG shows sudden change in the EEG frequency, which means there is sudden alpha waves or more than 16 Hz waves, then we can consider it as arousal. If frequency changes at least 3 seconds, it must be the frequency change at least 3 seconds. Before arousal, there must be at least 10 seconds stable sleep. EOG, there is no specific criteria. EMG also, there is no specific criteria. In the non-REM sleep, if the REM sleep, there must be at least 1 second of EMG activity. This arousal in the non-REM sleep, you can clearly see there is arousal more than 3 seconds, and there is a 1 second of EMG activity. So once the arousal happened, then the sleep will be fragmented. Then the sleep stage will stop, then the next sleep stage will come. For example, if the patient on N3 sleep, there is arousal, then patient will go to the N2 sleep. Arousal events, we can measure a number of arousals and arousal index by the help of total sleep time. Number of arousals into 60 minutes by total sleep time, we can measure arousal index. Then respiratory parameters. In the respiratory parameters, we need to see apnea and hypopnea. Apnea, the amplitude of airflow waveform drop by more than 90% when compared to the pre-event level with at least 10 seconds. Here you can clearly see 90% drop of the airflow with 10 seconds. For the hypopnea, you can see 30% of the airflow drop at least, which means more than 30% of the airflow drop for 10 seconds. Along with, we need to see the desaturation 3%. Otherwise, we need to get any arousal. Then we can consider this is as hypopnea. This slide shows various type of sleep apnea. One is obstructive sleep apnea. Here you can able to see there are a lot of chest and abdominal wall movements during apneic event. But during central apnea, there is no chest wall or abdominal wall movements. in the mixed sleep apnea, in early stage, there is no movements, but in the late stage, there are some chest and abdominal wall movements. This is the way we can able to differentiate obstructive sleep apnea and central sleep apnea, mixed sleep apnea from the polysomnography. And critical limb movements, yeah, placement of electrodes and anterior tibialis muscle for monitoring limb movements to diagnose the PLMS, major body movements with the muscle artifact obscuring the EEG for more than half of the epoch. If more than half of the epoch like this with much artifact, then we can't able to find out the sleep stage properly. So from the respiratory events, we can able to find out the apnea and hypopnea index. So the interpretation of the polysomnography, we can able to find out apneic index, apneic hypopneic index, or respiratory disturb index. Usually apnea hypopnea index contain apnea and hypopnea. In respiratory disturb index, some people use RERA also. RERA means respiratory effort related arousal along with apnea and hypopnea. So the interpretation here is if less than 5 events per hour, then we can consider as normal. If 5 to 15 events per hour, we can consider mild sleep disorder breathing. 15 to 30 events per hour, moderate, and more than 30 events per hour, severe sleep disorder breathing. For the diagnostic criteria for OSA, respiratory disturb index more than 5 events per hour plus clinical symptoms, or respiratory disturb index more than 50 events per hour without clinical symptoms, then we can consider OSA. This is the PhD sample for the PhD report. You can clearly see the sleep summary here, total sleep time, sleep latency, sleep efficiency, and apnea hypopnea index, how many obstructive event in the apnea hypopnea index, and oxygen desaturation index, we can able to see clearly, and arousal summary, you can able to see clearly arousal index, everything here. This is the hypnogram of the whole sleep study, which consists of all the respiratory, sleep stage, cardiac and limb movement and arousal movement, everything we can able to see here. Here I want to say, once we done the sleep study, there are two kind of titration. One is same day we can do this titration, and another one is the next day we can do this titration. The same day titration study called split night study. Patient usually do 2 hours of diagnostic polysomnography. In the 2 hours of diagnostic polysomnography, if we find out respiratory disturb index more than 50 events per hour or 20 to 40 events per hour with prolonged apnea or prolonged desaturation, then these patients we can consider to take same day. That's for the titration study. It's called split night titration study. In the split night titration study, we need to do at least 3 hours of titration for the patient. With this titration, if you achieve maximum pressure with optimal level of AHI, optimal level of AHI means if less than 5 events per hour, then we can consider this as optimal level of AHI. If we could not able to come to optimal CPAP pressure, then we need to do again titration study, a whole night titration study. Mainly more than 18 years, moderate to high risk OSA patients, we used to do split night titration study. Then newer technologies for sleep staging or consumer sleep technology. There is a peripheral arterial tonometry, cardiopulmonary coupling, heart rate modulation during sleep, respiratory pattern, actigraphy, photoplethysmogram, and ballistocardiogram. Here, the peripheral arterial tonometry is the FDA approved one. Actually, these newer studies which help to overcome the limitation in the home sleep test we already discussed. Like we could not able to sleep stage in the home sleep test. we could not able to find out the position. We could not able to find out the whether patient on the REM or non-REM sleep. Okay, so in this peripheral arterial tonometry, we have 3 parts. One is actigraphy, and another one is pulse oximeter, and third one is PAT, peripheral arterial tonometry. With the help of peripheral arterial tonometry, actually the mechanism behind the peripheral arterial tonometry is based on the changes in the sympathetic tone of the digital blood vessels. During the changes in the sympathetic tone, we can able to find out the sleep staging. There is a promising device name called WatchPat from Israel. They are using this device for the home sleep test. It's a one-time use device. So the result of the device, the Journal of Clinical Sleep Medicine, they said there is a high correlation and a good agreements in AHI and saturation between the WatchPat 200 and polysomnography. So there is a case we named.
Thank you, Dr. Boobala Aravinthan. I think we'll skip the case Vinay for now. Thank you for your presentation. Now our chairperson will address you.
Thank you, Dr. Boobala, for the wonderful presentation. Now session is open for any question.
Any questions? Any questions from other participants?
So we conclude the session. Thank you very much.
Thank you. Thank you, Doc.
Thank you, Dr. Boobala Aravinthan, for your engaging informative presentation on polysomnography. Your detailed breakdown of the components of polysomnography and its critical role in diagnosing sleep disorders such as sleep apnea and narcolepsy was incredibly valuable. The clarity with which you explain the diagnostic process will help many of us improve our approach to identify sleep-related issues on our patients. Your insights into the importance of early detection were truly enlightening, and we are deeply appreciative of the knowledge you have shared. Now, thank you, Dr. Verma, for your impeccable chairmanship through this session. Now, we request Dr. Venkatesh Madan Kumar to felicitate Dr. Verma for his leadership and valuable contribution. As we approach the conclusion of today's conference, I would like to express our sincere thanks to all our esteemed speakers, chairpersons, and participants for making this event a great success. Your contributions today will undoubtedly enhance our understanding of sleep and its profound effects on mental and physical health. On behalf of organizing committee, thank you for your presence and participation. We hope to see you in future events. We will now take a break for lunch. Thank you. Now, Gopinath sir will give a vote of thanks on today's conference.
So I thank all the participants who have come offline and who are here with us online for attending this conference and making it a big success. I want to thank the chairman, Dr. Jagatrakshagan, chairperson, Dr. Sree, and managing director, Dr. Elamaran sir, for providing all the resources and support and all the necessary things for making this conference a big success. And obviously, I thank our dean for gracefully kind of being here and inaugurating the session along with our advisor, sir. And a sincere thanks to our HOD for taking the lead and streaming us all through and making this conference a big success. And the team, our team of doctors, starting from Srinivas and Farana and Gayatri, Monisha, Ramya, and our postgraduates. And last but not the least, our secretary and all that also definitely has made this conference a very good success and PGs. But the conference wouldn't have been a big success without our resource person, our renewed speakers, starting from Devaki ma'am and Venkatesh Mathan sir. Thank you, sir, for sharing your insights, and Dr. Deepa Gopinath, and our speakers from Dr. Joel and Boobala, and also from Kuwait. He has also shared his beautiful insights and knowledge about the topic. I hope everyone has really enjoyed and got a very good knowledge about the kind of sleep 360 in total. And with this, I conclude the session, and I thank all the participants, especially the online participants and across the country, for participating with us and making this occasion a big success. Thank you.
नायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे